Good morning, colleagues. I would like to open the session by resuming the work of our yesterday committee meeting, which was a very interesting meeting with the participation of Commissioner Vice President Chinas, Dr. Ugarte of PAO, Professor Moon, co-director for the Institute of International and Development Studies, and Mr. Einekel from Doctors Without Borders. And I think we heard a lot of interesting insights. Today we continue the work on the second pillar, that is about the global issues, and I think it's important that we more or less can conclude the second pillar today with four very interesting exchanges of views. We have today interpretation in Dutch, German, English, French, Greek, Italian, Portuguese, Romanian, Spanish, Swedish, Czech, Polish and Croatian. All the invitees today will be online. That is a little bit related to the fact that we are in the international dimension of our COVI committee. If there are no remarks, then I would like to proceed to point 7, and that is an exchange of view with Ms. Samia Saad, Executive Director, Resource Mobilization and Investor Relations, from the Coalition for Epidemic Preparedness Innovation, better known as CEPI. We will discuss with her issues related to experience of CEPI action for preventing and mitigating the pandemic, the main lessons learned, of course, from COVAX, and perspectives from diversification of R&D and manufacturing for low and middle income countries. Thank you for being here with us today to hold this exchange of view with COVI members on the COVID-19 pandemic. We have 1 hour, so it's a smaller session for the discussion, and it will be conducted as we are used to. Can I please give the floor to Ms. Samia Saad? I hope you are online. Okay, you have to press the speak button. Ms. Saad, you have to, yes.
Yes, good morning.
Good morning, Mrs. Saad. Very happy to have you here. And I give you gladly the floor to make your introduction. Thank you very much.
Thank you very much. And I'll try and cover some of the points I understand the committee would like to hear. I know that you have already heard from our partners, Gavi, on the procurement side of pieces. What I'm going to focus on today is the Coalition for Epidemic Preparedness Innovation's role, CEPI, which is funding the R&D for emerging infectious diseases. Many of you might know that CEPI was created just post the West Africa Ebola crisis because it was very clear that was very few working on research for emerging infectious diseases where there's market failure. We were launched in 2017, and we were all working on priority high-risk viruses and pathogens based on the high priority list, what called the R&D blueprint of the WHO. And one of those viruses that we were working on was another coronavirus called MERS, the Middle East Respiratory Syndrome. And because when COVID hit, in late 2019, early 2020, we were working with partners already on different vaccine platforms, and some of them were supposed to be rapid response platforms in case of an outbreak of an unknown pathogen, what we call pathogen X. We were able to pivot very, very quickly with some of our partners that were working on this other coronavirus, MERS, to start developing vaccines against COVID. And in fact, we were faster than anybody else in the world. Within 12 days of the sequence being published of the new virus, SARS-CoV-2, we made our first catalytic investment in an mRNA platform, it was Moderna actually, to try and make sufficient material to start conducting a clinical trial. We built up a first wave vaccines, a portfolio of 9 vaccines rapidly based on 3 key criteria, which were speed, scale and access. That was the first wave, but to date we have now a larger portfolio which also includes second generation vaccines as well as what we're calling broadly protective SARS-CoV-2 vaccines, but also as part of our next 5-year plan, which kicked off in 22, we have also working on what we call pan-coronavirus vaccines, so trying to hit multiple coronavirus vaccines together. So let me just start specifically on access. Access is core to why CEPI was formed, so equitable access in terms of making sure nobody is left behind in LMEX. And has access to any of the the emerging infectious disease vaccines is core to CEPI's mission and why we were founded. And when COVID hit, we rapidly saw that the market was being cornered unfortunately, by high-income countries, so trying to secure doses. And we were very concerned that LMEX would not receive any COVID vaccines. So with Gavi, we came up with the idea of the COVAX facility and soon partnered with the WHO and UNICEF to create COVAX. And COVAX at its heart was really to try to make sure that any of the R&D that CEPI was investing in and more broadly would procure vaccines on behalf of LMEX, but also self-financing countries, because what we wanted to try to do to stem the tide on just high-income countries.
Oh, that's not so good.
Can you not hear me? Sorry.
Yeah. Yes, you were just a few seconds offline, but now you're back.
I'm
Please
sorry.
continue. Thank you. You can continue.
Can you hear me now?
Yes.
Okay, I will continue. So equitable access is at the core of CEPI's mission, and we welcome all initiatives to improve access to life-saving vaccines and medical tools to people all around the world. We can't wait for the next global crisis to establish these kinds of incentives, capacity and partnerships needed to enable more efficient technology transfer to vaccines in vaccine manufacturers in low middle income countries. CEPI is committed to that agenda and is supportive of continuing efforts at the World Trade Organization to drive the necessary trade policy changes to facilitate more rapid and equitable access. Our COVID experience was that non-tariff barriers also did impede the access objectives. So sustaining national and regional supply in inter-pandemic periods is an extremely complicated exercise. So the business model around this needs to be thought through quite well. It includes aspects such as building quality, sustainable vaccine manufacturing capacity, as well as creating the necessary supply chains, logistics infrastructure, and also delivery within a viable and robust business model. This must be pursued in a coordinated fashion with appropriate political buy-in. Otherwise, future vaccine manufacturing facilities will risk being unsustainable, inefficient, and unlikely to meet the global demand to enable equitable access during the next pandemic. The agreement on TRIPS is potentially a significant development for future pandemic preparedness, but it is not the only tool. Successful tech transfers rely on more than patents only. I think you heard from Dr. Barkley how complicated making vaccines is, and especially as well scaling up some of these new technologies that have been proved to work during COVID. CEPI believes in and operates by an approach where our awardees commit to supporting technology transfer to predefined partners if required. So rather than requiring ownership of intellectual property, we believe this is a better way to address the multiple barriers to development of vaccines, and hence the most effective way of delivering accessible vaccines as quickly as possible without stifling innovation or delaying the urgent vaccine development processes. There's an unexplored opportunity to incentivise technology transfer and enable equitable access through country and regional R&D investments and procurement agreements, such as in the EU, for example. R&D funding agreements could mandate transfer of technology and associated intellectual property to qualified manufacturers in different geographical locations, and CEPI is playing an increasing role in this space. So sustainable manufacturing will also depend upon a transparent and robust supply chain that can enable production unhindered during a crisis. This is reliant on free flow of goods and cross-border trade and investment in suppliers, supply chains and infrastructure. So use of the COVAX Manufacturing Task Force Marketplace as a model, which CEPI and WHO and COVI set up during the pandemic, because what we were seeing was that there were barriers to export of certain supplies that were needed to manufacture vaccines. And what we did is create the marketplace to matchmake different makers of raw materials and vaccine manufacturers, and we managed through that marketplace to increase the supply of COVID vaccines. Last but not least, in addition to predictable, sustainable financing for preparedness, manufacturing facilities will need access to surge funding to adapt and scale production in a crisis that is available at risk. And this is really important because this was not available during the COVID crisis, to allow for the seamless transition from preparedness and response required in an outbreak. And just to highlight that CEPI, as part of its R&D investments, had to use what we called recoverable loans to secure doses or first refusal of doses for the COVAX facility, because there was no financing at risk that was available in order that we could get supply to low middle income countries. Some of the main lessons from COVAX, I think you heard
Was the connection tested beforehand?
Yes.
And it was fine? Can we try again?
Can you hear me now? Apologies.
Yeah, you're back. Yeah. This is live online.
Yes, I do apologise.
No problem.
The internet sometimes is a bit unstable. The seamless transition from the development through manufacturing and to deployment and delivery of vaccines is critical, and this must be underpinned by robust and sustainable financing. That is one of the key lessons that we learnt from COVAX. The funding to purchase vaccines was not readily available. Neither was the funding in the first instance for developing a candidate portfolio of vaccines. So we had to all fundraise from scratch. CEPI had money for preparedness, we had some contingency funding, but we had to fundraise from scratch, as did Gavi and the COVAX facility, in order to make the advanced purchase agreements. The additional piece that we learned, that surge financing available at risk when an outbreak occurs, is critical. That was never available. Currently, even with discussions that are ongoing, nobody's really talking about that surge financing at risk. So while donated doses additionally need to be planned, happened during COVID, they did not happen anywhere quickly enough. And often they were donated with short shelf lives, and that was not attractive to countries because they were not going to be able to deploy them fast enough. So if there are donated doses, they need to be planned in advance. So there need to be access agreements by the high-income countries already that includes numbers of doses that will go to LMEX. Vaccine nationalism had a huge negative impact, as we all know, on vaccine access early on in the pandemic. And I talked about the high-income countries, unfortunately, cornering the market and reserving the limited supply. The fact that manufacturing capacity was concentrated only in a handful of high-income countries exacerbated these supply issues. So manufacturing capacity needs to be better distributed around the world, including technology transfers that need to be incentivized and planned for. Would have not succeeded as well. The other lesson that everybody should really be aware of is that We would have not succeeded in rapid development, safe and effective vaccines for COVID-19 without decades of investment in similar viruses, whether it's MERS, SARS, and platform technologies such as mRNA vaccines, vector-based vaccines, and protein subunits. CEPI had made a number of coronavirus investments before the pandemic, which enabled us to really pivot quickly, as I said, during the SARS-CoV outbreak. We must invest in R&D preparedness now, and this is a crucial component of both preparedness but also response, so that we can respond rapidly. And CEPI has set a goal for ourselves and the world to be able to compress the time and shorten the time to development to just 100 days. And we must coordinate critically between therapeutics, vaccines, and diagnostics, which is why the ACT Accelerator, and we're proud to be a founding partner with others in the ACT Accelerator. Let me just move on quickly, because I'm conscious of time, and really tackle a piece around CEPI's role in the diversification of R&D and manufacturing in low and middle income countries. So CEPI was working with multiple product developers, and we also, as part of our portfolio, helped with support tech transfer to others. So several of the vaccines that were actually received emergency use license, such as Oxford AstraZeneca and Novavax, that were supported by, amongst the many that were supported by CEPI, we supported the technology transfer to try and diversify during the pandemic. It was not enough, but we had other partners in other geographies, such as Biological E in India and SK Bioscience in Korea. And both Biological E and SK Bioscience have now approved for domestic use, have got license for the vaccines. 15 vaccines are still being funded by CEPI, including 12 variant-proof and broadly protective coronavirus vaccines. So CEPI is the only public sector funder of R&D which has leveraged its investments to enable equitable access. And what we are doing now is we sort of, through a call for proposals, we've identified a network of preferred partners almost on each continent, apart from Antarctica, but on each continent, so that in future there is a robust set of manufacturers, preferred manufacturers, that have gone through due diligence, and where we're supporting building that capacity so that they can participate in any rapid scale-up of manufacturing for any future outbreaks. We will be announcing shortly that network of preferred manufacturers. So that's one of our key commitments that we'll be doing and continuing to do in order to geodiversify the vaccine manufacturing capacity and capability, so that the supply provision in underserved LMIC regions happens. So let me just move on then to another aspect, which is do we consider whether high and higher income countries played a constructive role in the process of coming to a meaningful agreement within the World Trade Organization as a response to the pandemic? Let's just look specifically at trade policy shifts that are going to be needed to assure an enabling environment for scaling up and scaling out, and scaling up of global manufacturing. The World Trade Organization Ministerial Declaration MC12 provides that the WTO and its member states will continue to analyse and develop policies to address the lessons of COVID-19 pandemic. It's important that those discussions also consider stricter rules on the use of export restrictions. This was a major issue during COVID-19, and I can't emphasise that strongly enough. So it is really important to look at the rules that govern use of export restrictions on pandemic-relevant vaccines, therapeutics and diagnostics, as well as related to raw materials and critical supplies, which were also an issue and a barrier to scaling and diversifying the supply of vaccines. Especially when it comes to shipments intended for humanitarian and equitable access mechanisms such as COVAX. Moreover, CEPI encourages consistency and simplification of regulatory review processes, good manufacturing practices and product labelling in order to promote timely access to safe and effective COVID-19 vaccines.
Mrs. Saad, I have two messages. You talk really very fast for the interpreters, and also you should wrap up.
Yes. Okay.
That's two messages that are in contradiction. I'm aware, but you can go. There will be a lot of questions, and then you can go into
Let me then wrap up then with a last piece, and specifically, I think there was an interest in how CEPI tackles and ensures that vaccine prices are as low as possible. Let me just start by saying CEPI, when it was founded, was very focused on preparedness, and in the early sort of contracts, we were building a candidate pipeline, and so for some of them, it was very early in the development stage where price points and formulas could not be defined, or if there was no manufacturer involved. However, pricing formulas started to be developed more robustly from the times of COVID, and it was really based on putting into practice closely aligning price levels to cost, what we call cost of goods, in a not-for-profit, no-loss for LMICs. And LMIC pricing was not to exceed lowest upper middle income and HIC pricing or tiered pricing based on income levels. And we have published, and I shared with your colleagues who are secretariat for the committee, our access provisions in our contract so that you can see them. They are all publicly. We have done a summary of the approaches that we have used. And they are online. So with that, I will just stop because I'm sure you'll have specific questions that I can provide some more details on.
Thank you very much, Mrs. Saad, for this introduction. I immediately go to the political groups. Mr. Kimporopoulos, please.
Thank you very much, Madam Chair. And I also thank and welcome Ms. Saad for being with us today. We were delighted to hear about the recent joint letter between CEPI and HERA. There is indeed significant potential towards supporting the development of medical countermeasures. And this letter is a very important step in this direction. On funding, we need to remind ourselves and our citizens that the EU has done a lot in the international fight against the pandemic. You have spoken about COVAX. We have the Horizon 22. We have Horizon Europe. We have donated billions of doses and billions of aid to assist the developing countries. And in this regard, I want to ask you, how have you seen the resource mobilization against COVID-19, and what can be the main lessons learned for the future? You spoke about that, but we want to be more specific. Thank you very much.
Thank you very much. On my behalf, I have two questions, a general one and a very specific one. The general one is, you mentioned often, and of course it's really very important, that equal access is in the core of what CEPI does. Can you, in just a few sentences, evaluate the role of the European Union in that, both on the money available, the donations, but also the role on the discussions on the TRIPS waiver? My second specific question, yesterday we had a very interesting hearing with Professor Moon, and she dropped the idea of regional R&D funding pools where that different countries would work together, subsidize together research and development, and in return they get access to the technology without any patenting, as a sort of new model for the future to prepare ourselves for next pandemics. You also mentioned the fact how important it is to work on research and development preparedness. How would you assess that idea? I give you the floor, Mrs. Saad, to answer these questions, and then we go on.
So let me just pick up the first question, which was absolutely the EU played a major role in enabling access. However, like many high-income countries, some of that role came a bit too late with the dose donations. But just to acknowledge the long-standing partnership that CEPI had with the European Union's Horizon 2020 programme, and then through Horizon Europe as well, which continues. We received co-funding from Horizon 2020 to work on two diseases, chikungunya and Rift Valley fever. But when COVID hit, the European Union also committed 100 million euros towards CEPI's work to create candidate vaccines for COVID-19. And out of that, actually, was one vaccine which was a vaccine based in Korea, and it's the first homegrown vaccine that was supported with co-funding from the European Union, CEPI, and the Bill and Melinda Gates Foundation. So it was diversifying where these candidate vaccines were being developed so that they also could be manufactured elsewhere. So that piece around the R&D funding, and I will pick up the chair's question, it was not easy to fundraise for R&D. We did not have financing. We had to use contingency to kick off our R&D funding for the vaccines. But the European Union hosting the May 2020, President Ursula von der Leyen co-hosting with the WHO the May 2020 event to raise funding for Act A really helped bring in financing for CEPI. So in that role, that leadership role, that was really critical for CEPI and all Act A partners, that there was political will and leadership led by the European Commission as well as the WHO to try and raise financing. So we raised quite a substantial amount of financing in that initial wave, and we needed to build on that in order that we raised our almost 2 billion investment case to create the candidate vaccine portfolio. And remember, you need to invest in multiple vaccines right at the beginning because you don't know what is going to work. Back to HERA very quickly, the letter of intent. It's important that the challenge with the whole space of emerging infectious diseases and when outbreaks happen is that having fragmented research, having fragmented and not networked manufacturing networks, is why we are basically we did not make as much progress as we needed to. And ACT-A and COVAX are unique because it did bring different partners with different end-to-end expertise together to try and rally and make sure that was equitable access around the world. The letter of intent is really to try and make sure that regional entities, new entities like HERA, are partnering with global entities, with other existing national entities such as BARDA in the US, or now there's SCARDA in Japan, and other entities all around the world. The important thing is that we collaborate and we set out how we work together and we don't duplicate efforts, because there's a lot of work and for efficiency and efficiency of resourcing and know-how, it's really important to partner. And the letter of intent sets out how we're going to work together and leverage each other's capacities. CEPI both works on very focused on equitable access for LMEX, but also on pathogen X and rapid response platforms. And one of our visions for the 100 days is that we need to be better prepared and create what we call vaccine libraries, so prepared candidates for the 25 virus families that cause human disease. And partnering with organizations like HERA on because no one entity can do everything, so we need to partner on which areas are most relevant for the EU and then other regions of the world. So we're very excited about that partnership with HERA. We're also creating similar partnerships with other entities. And we see our role as a neutral broker, really, because we are a public-private partnership and can move quite rapidly, have good internal expertise that we're willing to share and partner with new entities that are being created on health security around the world. Madam Chair, on your question on the regional R&D, it is an interesting idea. We do think that solving making a more robust ecosystem needs to be looked at a regional level. But we also worry, you must make sure that science is driving the agenda and you have the ability to make scientific decisions, robust scientific decisions, and make investments quickly. So any regional entities need to make sure that they are really scientifically driven and have good accountability and transparency mechanisms for policymakers, but the science drives. So with any regional R&D or manufacturing, which is the way CEPI thinks, the world will become more resilient and robust. It's important, though, that any regional entities are networked, right? And that's really important because, again, you hedge your bets, you might not be making the right investments, and it's important to partner and build the know-how across different regions around the world. Over to you.
Thank you very much. Madame Trélène-Noir, s'il vous plaît.
Thank you very much, Chair. Thank you, Mrs. Saad, for your very good explanations to the crucial questions already addressed by my colleagues. As a medical doctor, I would like to have, if possible, answers to the questions that are raised to me from what I saw on your website. You are supporting the development by the Dutch Organization for Clinical Development and Vaccine Manufacturing, INTRAVAC, a vaccine against SARS-CoV-2 that can be administered by nasal route. And the preliminary preclinical results are promising. And many questions arise to me. The first one is, given the recognized efficacy of the vaccines already on the market, what would be, in your opinion, the methodology of future clinical studies? In other terms, is it really ethical to compare the administration of a candidate vaccine to a placebo? And the answer is in the question. Another one is, could the cost of this type of vaccine be more competitive than those already on the market? And finally, would intranasal administration, that is through local and general immunity, give better protection, but also maybe a better reduction in the transmission of the virus? Thank you.
Merci beaucoup. Jutta Paulus, please.
Thank you, Chair, and thank you for being here. Because of the large financial contributions to the research and development of new vaccines that were done by CEPI, we think you also expressed that CEPI has the potential to improve the equitable access to vaccines, because of course you could attach conditions to the funding. And you expressed very well that access was one of the primary goals, but unfortunately the bitter reality was that vaccines were not fairly distributed, so that even healthcare workers in the global south were at risk because they couldn't be vaccinated. So do you think your current policy guide provides sufficient tools to negotiate meaningful contractual clauses on affordability, availability, transparency, sharing of IP rights, and also promoting local manufacturing capacity in low and middle income countries? Are there plans to revise the policy guide after the inequalities which we have witnessed during the COVID-19 pandemic? And which solution would you, as a follow-up or a second question, which solution would you propose to solve the financing problem for scaling up production quickly in emergency situations? Would you envision, for example, something like an emergency financing pool based at the UN or based within one of the UN programs on global health, for example, which could be used in case that we need financing of rapid R&D of emerging threats? Or which kind of financing tool would you see there? And follow-up question, your CEO, Dr. Hatchett, recently commented in favor of access conditions on R&D fundings and sharing on technologies. And I would like to know, is this a concrete commitment for CP to adopt enforceable access conditions? Will you commit to sharing intellectual property rights and technologies to manufacturers in the Global South? We had a hearing yesterday where it was very well laid out how publicly funded research could lead to a vaccine that is really affordable and really accessible for a lot of people for as little as €3, where the publicly funded research and development led to a licensing in India, for example, which really helped India out with their vaccination campaign. Thank you.
Thank you very much. Mrs. Saad.
Can you hear me?
Yes, we can hear and see you.
Okay, so let me just say, while I'm a molecular biologist and cell biologist by training, I'm not a vaccine developer. My role within CEPI is to work with governments and philanthropies really to make sure we bring in financing and partnership for the work that CEPI does. So we can certainly follow up on the Intravac question, but I think what we realise for sure is that we need better, we need second generation vaccines. So the first wave of vaccines really had a really high impact in terms of creating an immune response, preventing severe disease and deaths. But we hope we are not out of the pandemic completely, but as we move from sort of the acute phase to having an endemic virus, we will need better tools, and that's why CEPI is investing. Plus, some of the vaccines that we have are not thermostable; they need to be frozen at -80. We need multiple doses, etc. So CEPI is working, and Intravac is part of a second generation of vaccines. To find different delivery mechanisms. Your point about can we get better mucosal because immunity through an intranasal delivery mechanism. These are things that we're testing, right, to try and see, because there will be other respiratory viruses as well. So it'll help advance the science more broadly for respiratory diseases. So I will leave it at that, but happy to follow up with some of my R&D colleagues who can provide some more details on that investment, what we hope to achieve out of it. But we do need a second generation of vaccines, and CEPI and broadly protective SARS-CoV vaccines, because the virus is still mutating, and we need to keep ahead of it. And the way to be ahead of it is to have a broadly protective vaccine, but also work on beta pan-coronavirus vaccines in case there are future coronavirus vaccines that that come up in the future. On the access pieces and IP, our access terms we've always had an access policy, even pre-COVID, right? There are always access terms that are negotiated as part of our R&D contract, and that was the case during COVID. I do want to point out that the reason for non-equitable access are multifaceted, and they are not just related to IP or access terms that you bring in during the R&D phases. It was because high-income countries cornered the market. It was because the dose donations didn't happen quickly enough. It was because without money committed by high-income governments and middle-income governments rapidly, you cannot make advance purchase agreements with no money, and there wasn't a surge financing facility to do that in, right? So the money came in not as quickly as it needed to be if we were going to try to have equitable access. And then there are multifaceted other issues, whether it's vaccine hesitancy as the waves of COVID were coming down, demand, etc. So lots of different multifaceted reasons for the inequitable access. But to say CEPI's role, which is really in the R&D piece, so we don't negotiate the procurement deals, others do, such as the COVAX facility, whether it's UNICEF or regional bodies, etc., or local high-income government procurement agencies, etc. So CEPI does not seek to own the intellectual property as part of our policy, and the reason for this is that, contrary to the situation with small molecule medicals, there are no barriers to development of vaccines, or there are more barriers to development of vaccines than just patents. It is a complex business to make vaccines and biological materials, and the know-how and trade secrets, as well as access to biological materials such as cell lines and the regulatory approval for platforms, in particular things like adjuvants, which help make a better vaccine and better immune response. So moreover, the vaccine developers relying on a platform to develop vaccines will want to ensure that their technology is managed properly so that it is available to develop other vaccines. So CEPI's approach is to really require awardees to manage the IP in such a way that equitable access can be realized, so fostering technology transfer, for example. And in the case of COVID-19, doses were made available to the COVAX facility for fair allocation and procurement. So we secured almost 2 billion doses through first right of refusal through the R&D contracts, and then they could be procured through COVAX. And just to say that we've learnt many lessons through the process, and we are updating our access policy. And you can see, as I said, how we've applied the approach to access and how we managed to secure first right of refusal for the COVAX facility of up to almost 2 billion vaccines through our access agreements as part of the R&D investments.
Thank you very much. Mrs. de la Pisa.
Muchas gracias.
Thank you very much. CEPI, the Coalition for Epidemic Preparedness Innovation, was created at Davos in 2017 after Ebola, with a great amount of financing from the Bill and Melinda Gates Foundation. And that has a seat at the Council. Its mission is to develop vaccines and other biological responses to threats and pandemics so that they can be accessible to everybody who needs them. That is the definition of the organisation. Now, in truth, I don't really understand it. I don't really understand the crucial role that CEPI is supposed to play. It's clear here that the actions of the WHO and the EU are always supported by philanthropic endeavours such as COVAX. And philanthropy is welcome, but seeing how international pandemic preparedness is based on a private initiative where plurality and democratic representation is not guaranteed, naturally there can be conflicts of interest. You said it yourself when you spoke of the plan. Changes in trade policy, the network of manufacturers, prices, quantities, profit margins, IP. It almost sounds like you're legislators. I can only manifest my astonishment at how much influence organisations such as yours have, and it worries me that institutions such as ours and the EU is being overrun. They're talking about the EU as a partner. Countries are no longer international players and stakeholders, and foundations and organisations such as yours have taken their place. This was created, I reiterate this, at the Davos Forum in 2017. I would like to be reassured. Perhaps I haven't understood CEPI's role properly, and I would really like for you to explain to me better how it is involved in international decision-making, such as during the pandemic. Thank you.
Very much. Mrs. Donato.
Thank you, President. Thank you, Mrs. Saad, for your presentation. Well, I need to wrap up very briefly what you told us. Well, CEPI was founded in Davos, The founders are two non-EU governments, Norway and India, the Bill and Melinda Gates Foundation, another foundation which is Wellcome, founded in 1936, which is today an investment fund, where the board has as a chair Julia Gillard, the former Premier of Australia, and also still member of the WEF, where she's chair of the Global Partnership for Education. So she's in the WEF again, and WEF is one of the founding members. So so far, the CP, as you told us, has the purpose of collecting money in simple words, because it deals only with financing research and development to produce second-generation vaccines to tackle new global crises given from outbreaks of diseases, infective diseases. Well, as we know, and I today sent to Mrs. President a letter with attached documents, BioXiv research, assessing that the origin of COVID outbreak was a laboratory virus created in a laboratory with a gain of function research. As we know that, I think that expecting new pandemics as the one we are living, have lived so far, could not be a problem if we just forbid gain of function research all over the world. And all of this money collected by private and public entities, public money, which is given to, at the end, goes to multinational pharmaceutical companies that are not willing to share their patents, their IP, to other producers. So there is no, public interest purpose. It's just profit. They collect huge profits. So I think that, and also global manufacturing you were talking about is always reserved to the same multinationals. So my question is, why should public money be collected and be given just for big profit purpose and not for public interest? Thank you.
Thank you very much, mevrouw Fransen. Cindy?
Thank you very much. Many thanks for giving me the floor, and I will indeed address some questions today. As we all know, sorry, but I think it was for the next speaker. I'm sorry.
You are on my list, Cindy, but that's
no,
okay.
it's for Mr. Dlomo. That's the reason why I was
a
bit surprised. So thank you.
Okay, if nobody else wants to take the floor, I give back the floor to Mrs. Saab. Thank you.
Thank you. So just to clarify, we are, the founding partners were a few governments and two philanthropies, but the number of governments expanded quite a bit during the COVID pandemic. So we were funded, and we have an investors council that has full visibility of the portfolio and to create an accountability mechanism. During the COVID-19 outbreak, I think we ended up having over almost between 25 to 28 countries that gave funding, from low and middle income and high income countries, and several European countries, including Italy, Germany, the UK, Lithuania, Luxembourg, Spain made a pledge as well. So several European countries, Serbia gave us financing. So several European countries also gave financing to CEPI, because we were, this was pre-HERA being set up. And we were the only organization that was really including equitable access right from the get-go, and with that in mind, that nobody should be left behind, and access to LMEC. So the decision-making sits with a scientific advisory committee and experts. And there was an external research, development and manufacturing committee with international experts that were not direct. They were not sitting in pharmaceutical bodies. There was no conflict of interest, but they were ex-pharma experts with product development and vaccine development expertise that were helping us look and do due diligence on the investments. And every single contract had speed, scale, and access as some of the key criteria that were guiding making those investments. So I do want to highlight that we are a public-private partnership, no private sector financing, as in no pharmaceutical industry financing comes in to CEPI, and there is private sector that is from non-pharmaceutical companies, but they do not sit in any of the governance bodies. They are donations, and then they just they are contributed. But largely, the funding by far billions and billions. So I think from a few smaller foundations and maybe some corporate social responsibility, like Citibank, for example, that amount was 25 million. But the largest amount of funding is from over 25 countries that came in for COVID-19 to make up our 1.8 billion in resources. And just wanted to clarify that. Then going to some of the other questions so we have a strong advocacy responsibility, and our role is in investing in the R&D with access commitments that enable equitable access. And as a reminder, we did secure first right of refusal through our securing doses through the R&D contracts on behalf of the COVAX facility. So we coordinate and engage, but final decisions are left to countries and multilateral orgs. We don't do the procurement. We invest in the R&D with the access conditions. And as I said, we built a portfolio that was very diverse. As I said, the vaccines that were developed weren't only in high-income countries. We now have 2 vaccines, one in India and one in South Korea, as well, that were funded and have received emergency use license at the national level. So diversifying the footprint of both R&D and where the manufacturers are is key, we think, to global access and to sort of diversified capacity around the world. Our interventions are really to support and enable. Just want to highlight that there is no evidence that the WHO has found that COVID was a lab-created virus. And monkeypox and the current Sudan Ebola virus are examples that outbreaks and spillovers occur all the time from other animals. We follow the science. That is a really critical piece. So our role really is to ensure, as I said, that equitable access terms are in our R&D contracts from the early stages, but then we need to partner with procurement agencies once there are outbreaks, so that these vaccines go through the later stages of development and can be procured. Germany was an investor since 2017, so I did want to highlight again the diversity of the investors. You can go to our website and it's very transparent, the diversity of investors and largely public sector funding. We do constantly advocate. Our role in advocacy is for reduction in barriers to technology sharing, and successful tech transfers rely on more than just patents. So where patents are a barrier, we advocate for voluntary licensing and participation in the medicines patent pool and other mechanisms to broaden manufacturing capacity and enable access. And our our commitment to creating a distributed around the world manufacturing network is one of those commitments. And as I said, we did facilitate technology transfer for the companies that were developing vaccines with some of our R&D money, so that there was distributed manufacturing, not just in Europe and North America, but other parts of the world, to sort of try and help avoid having vaccine nationalism and export bans. So that continues to be a role that CEPI will play, and our preferred network of partners will be partners for technology transfer from some of our R&D partners. So our role in really being that bridge, being that technical advisor and matchmaking to help facilitate is core to one of the approaches that we have to enable access. Over. Back to you, Madam Chair.
Thank you very much, Mrs. Saab, for being here online, but being here, take the time, answer all these questions. And we move on now to point number 8, that is an exchange of view with Dr. Delomo, Deputy Health Minister of the Republic of South Africa. And can I say, Dr. Delomo, we are very proud and happy and honored to have you in our committee. We had in this last 2 days, we had many important guests, academia, we will have the WTO, the WHO, we had experts, we had NGOs, but it is very important that we also have somebody with political responsibility from the Global South, and not just any country from the Global South. South Africa has played in many aspects a very important role in this pandemic. We all remember that Omicron virus was detected in South Africa, and at that time South Africa did everything that was necessary to alert the rest of the world, as every country should do. South Africa did that, but the reaction of the rest of the world wasn't as it should be. They started closing their borders instead of immediately go to the aid and the help, and because these variants, that's what we learned in any case, they will cross all the borders, not just borders of neighboring countries, but borders of continents. So it would be interesting to see your views on that. And of course, you played a very important role in the whole TRIPS waiver discussion. You were, I think, very courageous at that moment. It was not easy, and you also played a very important role in local production and tech transfer. So many reasons why we are very happy to have you here, and I'm very looking forward to your introduction. Mr. Delomo, Mr. Minister, you have the floor.
Oh, good morning to Ms. Kathleen Van Bremt and the rest of the leadership that is here. I'm Dr. Delomo, the Deputy Minister of Health in South Africa. I am tasked here to represent my minister in this meeting, who is out of the country. We are very privileged to have been invited to share our lessons with you on our country's response to COVID-19 and our perspective thereon, hopefully to improve the international response for future health emergencies. We are also hoping that this is going to assist the whole of Europe in also to deal with the future crisis in the future. But also we would learn from yourself after we have actually compiled a comprehensive report on this part. So if I may then request the host to move me to the next slide, please. That we have the good and the bad, and the good is the one that I've indicated with the tick, and the bad is, or challenges is there where there's a red cross. That we were actually coordinate. We actually understood, some of us though were physicians, but we knew that we need to have a support of the national committees of experts in our country, epidemiologists, virologists, microbiologists, and there was therefore a ministerial advisory committee for the minister that was dealing with the issues of vaccines. The one was dealing with the issues of the pandemic itself, and there was another one of social psychosocial responses, that is we from the society, what they are going to help us to guide us, what are the people are saying on the ground. We also had a very strong laboratory capabilities, both private and public, and we were also aware that some of our patients, citizens, needed just oxygen to get better, and therefore we strengthened that in our private hospitals, the reticulation of the oxygen, because we do already have that in the private space. And then some of our patients were ventilated and then were sent home. We had really made a very strong partnership with other organizations that are supporting us. Hence, we are probably one of the first early ones in Africa to get the vaccines. Our data was actually managed nationally within one space, both private and public, and we have really learned quite a great deal in terms of preparing ourselves as a country for public and private partnerships in terms of healthcare service delivery. Of course, we did have our own challenges that we probably would have wanted to respond a bit early, but we were not that early in terms of getting vaccines. Or our staff members were really depleted, very frustrated. Even to date, we are still dealing with the mental health issues that have affected even those families who have lost their loved ones who were healthcare workers and have moved on. Of course, the shutting down, though necessary, halted quite a lot of progress in our country in terms of the economy. We understood that it was necessary, but there were certain shortcomings, including our own patients not accessing medication to clinics and public hospitals because they were afraid of going in there. Of course, we later, even after receiving vaccines, picked up a lot of vaccine apathy from those who were actually largely coming in from the young people mainly, but we're very happy with the vaccinations in our country in terms of the adult population, which is way above 70%. Of course, our country was also engulfed with the equipment that was used for the vaccines and for the pandemic that was really going into the corruption space that is being still investigated for financing. Next slide, please. We have also strengthened our capacity in the country, and we are lucky that when we had two types of vaccines, the Pfizer and the Johnson & Johnson, we came to learn that the Johnson & Johnson could be even in the most remote areas because it could withstand only other weather conditions. But we are very fortunate as a country that we had a very good storage capacity of those vaccines that needed to be stored at minus 20 degrees and all that. We actually are coming in from a community that has really got its routine vaccinating children routinely, and therefore to explain to the adult population that look, there was no COVID-19 problem in 2017, so none of us are protected against it. We are to vaccinate everybody. Because of that, it became much easier to really take that message to the adult population. We then also had the challenge again with them. Like I've indicated, we not the first ones. We're still battling. We got our vaccines, yes, quite a bit late, and the vaccination deliveries were not really very smooth. They were erratic. Look, being not a country that is manufacturing, we waited. And we do know that we were probably put at the back of the queue, but not so much at the back of the queue compared to the other countries in Africa. We also had a very problematic attitudes from the companies that were supplying us. Nevertheless, we kept on moving. We then would want to speak to this issue of vaccine nationalization, that we should be able to say this product is good for me, for my neighbor, and it's good for all of us in the world. Therefore, we would not really wish to see a situation where certain communities were keeping the vaccines to themselves at the expense of the rest of the world, and the people could have access to it. So that became a challenge. But overall, in Africa, we are still much better than the rest of the other countries in Africa. Next slide, please. This is an issue that we think international responses must still be focused on. The issues of antimicrobial resistance, the surveillance thereon is an issue that we need to still focus on. We are really very delighted and hopeful that there are certain countries who are supporting us on this issue of global and regional forums and treaties. We need to strengthen those programs, especially to really develop the low and middle income countries, and also in particular the whole of Africa as a continent. The financing is a potential mechanism to create resource for strengthening surveillance and other pandemic preparedness in parts of the world that have little or no capacity. We need to really continue to invest in global equity and create a global solidarity that says this is good for me, I'm really benefiting from it, but who else is not benefiting from what I have? Can I really create that and really all of us be tied up into what we call a global solidarity? Farmer has proposed that governments should fund, support, and de-risk and provide data for drugs for research and development, including waiver any liability for companies to ensure their products are safe. We think this is not right. While countries are willing to provide samples of pathogens used for research, however, companies should be obliged to share the result drugs and technology that they have in return. Next slide, please. The key elements for the development of European strategy for the export of vaccines to less and low middle income countries is what we really would plead that equity should probably be our main focus. Acknowledgement of the access to clinical trial data, that we would want that essential to include different populations to ensure that vaccines are relevant and appropriate, include the researchers from the recipient countries also, so that we don't get things done for us without us, but we get things done with our experts too in the country, in our continent. Do not try to find solutions without the input of the people who the solutions are meant to reach. We try to be extremely consultative in our country, try to really reach as many so that they could have a buy-in to the product that we are developing, the same we are really wishing that it could happen. Explore how to assist local production in Africa. That I'm just repeating, there's a need to transfer the mRNA vaccine technology to the low and middle income countries and sustain those solutions that we are creating. That we would want to say, while we become recipients of this technology, but we should not necessarily be people who are not going to be paying for it. Yes, towards the end, the Global South cannot only rely on donation. Voluntary can offer a lifetime to the population, but are often too limited. Donations have proven insufficient, and less than half of the vaccine promised have been delivered by this year, June. I think they have a last slide, which is talking to... Next slide, Chair. Okay. All my conclusions say I still want to reiterate some of the things that I've said above. That South Africa and Africa have the positive and negative of the experience of COVID-19. I probably summarized quite a lot of here. If we could write a dossier, we could. Exclusion from early support during pandemics and global emergencies helps no one. We need to be part of us. All of us get to be started at the same foot, same step. Preparedness is preferable to scrambling for resources when the crisis arrives. So I think we need to learn from this to say, what do we do to prepare for our next pandemic as the world, and not only just Africa or as Europe. The world must learn from this crisis and adopt absolute global equity to healthcare as its goal. The treaties and plans are not enough. There must be deliberate and proactive action. All countries need strengthened health systems for adequate resilience. We too, we are pointing ourselves. We should not allow the notion that profits should be maximized at the expense of lives, health and well-being, environment, planet, democracy, state, and sovereignty. That health is a public good that all of us should aspire to have, not only for ourselves, but for our citizens, for other neighbors and other people. We want to follow up on the World Health Organization's advice and end secrecy in decision-making and cooperate globally. We also wish that we publish the evidence and embrace open research, even though sometimes when we had our researchers doing that, we got a backlash, but thanks very much that everybody seems to have now given us a space to say, yes, you do have a best of the South Africans who are experts. Your advice will be taken. The international cooperation will save lives. I thank you very much for this opportunity. I hope this is assisting in our discussions going forward. Thank you very much.
Thank you, Dr. Zlomo, for your very interesting introduction. There will be a lot of questions, and I start immediately by Mrs. Fransen, please.
Thank you. Thank you, Chair, and also many thanks to Mr. Glomo, I'm sorry, for being here with us. Today, as we all know, the global availability of vaccines is not really an issue anymore, but it has been for a big part of the pandemic. And it was your country that stood at the forefront, as already mentioned by the Chair, to try and solve this problem early on. We, of course, had the whole discussion on IP waivers, and we all know IP can be one of the many pieces of the puzzle. Technology transfer and production capacity are equally important if we want to find an answer to the question of regional production of vaccines. There are good examples in your country, such as, for example, the mRNA vaccine technology transfer hub and the Afrigene company. So I have some questions. What are the biggest hurdles the hub is still faced with? How can we better incentivize further technology transfers? Is the current international IP system taking into consideration last June's decision by the World Trade Organization Ministerial Conference fit for purpose if we want to scale up such examples? And if not, how would you change this to get to a robust IP system that incentivizes innovation on the one hand and has enough flexibility to adopt during emergency situations on the other hand? Thank you.
Thank you very much. Mrs. Cerdas, please.
Thank you, Chair. Thank you, Dr. Domo, for such inspiring presentation. And I would like also to start to thank you for your quick response on sharing your findings when Omicron variant first arose and was discovered in South Africa, and that allowed us for the rest of the globe to actually have a better preparedness and response. Unfortunately, you were not treated with the same solidarity and kindness by other countries when taking unilateral isolating measures towards South Africa. My question has to do with the TRIPS waiver. South Africa and India have called for the TRIPS waiver in October 2020, and you have faced many hurdles since then. It has already been said in previous hearings here at the European Parliament that some people won't agree with the TRIPS waiver because, and I quote, those countries would have the means to manufacture RNA messenger vaccines, end of quote. What do you have to say about this perception? And moreover, do you think that an existing mechanism should be in place to avoid the monopoly of intellectual property when we face the next pandemic? And how should international agents position themselves to avoid this situation that causes great global inequities on health?
Mrs. Cerdas, Dr. Dlomo, Mr. Minister, you have the floor to answer the questions. Let's try to solve this problem. Dr. Dlomo, Mr. Minister, you are back. Dr. Dlomo, are you back? And if yes, did you still hear the questions?
Crisp in South Africa.
Hello?
Hi, I'm not sure if you can hear me. It's the first time I'm using your platform.
We can hear you.
Okay, thank you. So
but we
I've
cannot...
just been informed that our Deputy Minister's power has been cut off and so he's not connected.
Okay, and it's not possible...
Power, yeah.
It's not possible to reconnect with the minister?
So the power in his area, he has no power, so he hasn't got a digital signal.
OMG.
It's raining here and there's a big storm, and so I'm not sure, but perhaps I can help respond to the questions, if I can do that.
And you are from the embassy, right?
So I'm the Deputy Director General of the National Department of Health.
Okay.
And I've been running the vaccination program during COVID. So the Deputy Minister Dlomo is one of my bosses.
Okay. Well, this is live. As we learned, the good thing about the pandemic is that we learned to connect remotely, and so we connect more easily with the rest of the world. The difficulty is that these technologies sometimes do not work. So if the colleagues agree, then we proceed with you and the questions. Is that okay? Yeah. Okay. And if you cannot answer the questions, then we resubmit them in writing. So that we do sort of, a hybrid way of working. Did you get the chance to listen to the two questions before?
Yes.
Okay. Then
yes,
I give you the floor to answer.
Thank you very much. So let me just give some high-level response, but I think it would be better if we get them in writing so that we get the Honourable Minister and Deputy Minister's sanction on the details. But we do still have existing problems with intellectual property, and we are engaged in a number of forums. In the World Health Assembly, we participate there, and we know there's a lot of activity going on at the moment. And so not everything is solved, clearly, and I think this will be an ongoing battle. And it's not just about IP around vaccines, but around IP of all the health products that we are dealing with. And that is a challenge for us in developing countries generally, and not just for us in South Africa. So the answer to the question is it remains a challenge, and there are a whole lot of initiatives that are going on to try and address it. We're well aware of the different perspectives and opinions on the TRIPS waiver. And as the speaker who spoke about this has been ongoing for some time. Indeed, it's not resolved. We don't think it will be resolved in a short space of time. But again, these things, we shouldn't wait for the next pandemic to engage with them, which is why we are happily participating in the various forums on pandemic preparedness, both in the World Health Assembly space and other forums. So we will be submitting ongoing inputs relating and dealing with our ongoing discussions related to TRIPS and to intellectual property in general. I don't want to go into any of the details now, but we can certainly see what we can respond to in writing as well.
Thank you very much. Ms. Trillet-Lenoir, please.
Thank you very much, Chair, and thank you, sir, for replacing the Deputy Health Minister. In his speech, he addressed a lot of questions we are also addressing at the European level in this Commission, but I would like to hear a little bit more on how you dealt with inequities, and you have mentioned the erratic process of distribution of the vaccine. What about the very outmost regions in your country and generally speaking in the African continent? How did you deal with misinformation and fake news? The Deputy Minister said that the problem was almost solved, so we are interested to know a little bit more about it. How did you deal with the impact of the pandemic on non-communicable diseases, such as chronic diseases like cancer, for instance, and on mental health? The Minister mentioned it, but I would like to hear a little bit more. And finally, how does the African continent, and your country in particular, address the question of One Health, global health, that is the virtuous cycle between human health, animal health, environment, and nutrition? Thank you so much.
Thank you very much. Mr. Grufa.
Oui, bonjour, merci, Présidente.
Thank you. I'm going to speak French. I actually have 4 questions. I don't know whether I can just ask them all 4 or one at a time. But anyway, first question is, how did South Africa see the use of COVAX to the access to the COVID-19 vaccine, and what do you think of that mechanism? And then, did you have any exceptions for the WTO, and what's your position during the CM12, and what type of contribution could the EU bring to the extension of diagnostics and therapies, and to what extent is it important for your country? Thank you.
Ja, vielen Dank.
Thank you for this opportunity for debate. Even with power outages, we can expect more of that in Europe soon. Most European countries have lower vaccination, or there are lower vaccination rates outside of Europe. Only a third have 2 doses, never mind 3. And yet the burden of COVID is lower in South Africa than in countries with a vaccination rate of 80%. So I'd like to understand why this is the case in your view. And what about regional differences on vaccination quotes? Has that had an impact on transmission of the virus? Are infection rates different depending on vaccination rates, and is that a positive or negative correlation across the regions of South Africa? And a very important issue, what do you believe is the impact of COVID-19 vaccination rates on health and the economy compared to other illnesses in South Africa, AIDS, malaria and the like? Thank you.
Danke schön. Mr. Crisp, is that correct? To answer the questions?
Much. I'm not sure I can answer all of the questions, but let me deal with the ones that I can. So inequity is a domestic challenge in our country. We have a 2-phase or a biphasic health system with a public and a private sector, where the private sector has huge capacity but serves a relatively small portion of the population, maybe 15 to 20% of the population. and then a public service which looks after the remaining portion of the population. And that inequity plays itself out in everything, not just in the health space. But for us in the health space during COVID, we needed to close that gap quickly, because we all know that these, especially infectious diseases, know no boundaries. And when people are ill, it doesn't matter what your socioeconomic status is or whether you have buying power in the health system. So we are embarking on health reforms to integrate to get one national health system. But during COVID, we set up very rapidly working teams between the public and the private sector. So in the treatment space, access to hospital beds, we were able to work closely with the private hospitals and make sure that should we need overflow beds to be available for public sector patients, that was possible. Obviously, things changed a lot from us using ventilation in the beginning to other ways of treating patients quite fast. And in the vaccination space, we, within the space of the first 3 weeks, integrated the vaccination by both public and private vaccination healthcare service providers, including private pharmacies, doctors, hospitals, and so forth. And we have had, in the beginning, we had a committee that met 3 times a week to make sure that we were integrating the systems. What was good for us is we managed to get everybody to use one digital data management system, both for the vaccination process and for hospital administrations and the laboratory services. So everything was on one common shared platform so that we could at least redirect resources and so forth. So we overcame to some extent the inequities, but sadly there are still massive inequities, and it will be many years before we are able to address them. And those inequities stretch socioeconomic and geographically into rural areas. There's not really a short-term solution to that, but we did manage to overcome some of it. There are inequities in Africa and in southern Africa, and we have very porous borders with the countries around us. So a lot of movement across our sovereign borders to our north, but we don't discriminate at all between who's moving the borders, especially for the vaccination program. So we were able to vaccinate a lot of people who move on a regular basis across the borders. Perhaps moving to misinformation and fake news. This has been a very, very big problem for us. We have had social media explosion in the country, and I mean the digital implications have been dramatic during COVID, some good, some bad, and the bad ones were that social media took over. And we have a program called Social Listening, where we have independent parties from universities and other agencies who provide us with these social listening reports that tell us what the perception is on the ground. And unfortunately, the public has lost confidence in government, lost confidence in health practitioners. They don't believe the science, and they were listening to all kinds of nonsense news, including overt anti-vaxxing news. So we have by no means overcome this, but we do have targeted responses, and we do have programs that we publish in 120, or put information out on 120 radio stations, but not everybody, especially not young people, are listening to the radio, and so getting to social media and trying to overcome that negative messaging is still a problem, and I think it will continue to be a problem, not just for health, but for everything that goes on in our communities. Turning to the third question from Madame Lenoir, is that we lost a lot of ground in not only non-communicable diseases, but also in our communicable diseases programs, notably our very substantial HIV program and our TB program. And people did not come for treatment, partly out of fear of getting into queues and coming into spaces where there are large crowds, but partly because we had to redivert all our healthcare workers to work in the wards and to work in vaccination programs. So we did lose ground. But we have a catch-up program that we are driving at the moment. HIV and TB are catching up quite we're encouraged by the amount of catch-up. But getting back on top of non-communicable diseases, our cancer screening programs and so on, We are not there yet. There's a lot of work to do. So I think we must acknowledge that that impact has been significant. We do have a long-standing program of measuring excess deaths, and whether those excess deaths were from people who died from COVID or with COVID from other conditions, we don't know. But we monitor very closely these excess deaths. And there have been as many as 300,000 excess deaths over the past 14 months. Obviously that's a worry. It's now under control again. We are able to watch it at quite a small geographical level, and so we can intervene quite quickly if we see a change in the incidence of excess deaths. Mental health is a big problem. I'm sure that we share this challenge with the rest of the world. For our healthcare workers, it has been extremely traumatic. People having to go into an environment, especially in the beginning where we didn't understand the virus, we didn't know how it was behaving, having to gown up into PPE that they weren't normally familiar with and didn't know if it was adequate to protect themselves, seeing some of their colleagues infected, getting sick, and many dying. We lost over 1,500 healthcare workers in hospitals who died from COVID. That has taken a toll on healthcare workers. And in the general public, of course, being locked down, because we had lockdowns in the beginning, and the stresses that comes with being confined to small spaces and in environments which is not part of our normal psyche, has definitely taken its toll. And we don't have the kinds of resources we would like to have to deal with all of the mental illness that has, which was already a problem before COVID, and it has been exacerbated. So I'm afraid we don't have all solutions we could tell you. Just to tell you that we definitely recognize the problem, and we do have programs. There was a question about Africa and Africa's position on One Health. I wouldn't like to speak for the whole of Africa, but we are engaged in forums in the continent. But for us, we have had several meetings even this week. And in fact, even today, the meeting I've stepped out of to come to join the Deputy Minister on this forum is on antimicrobial resistance, where the last discussion that I was involved in this morning is around the integration of at least 8 government departments so that we deal with a One Health scenario with the Agriculture Department, Climate, the Treasury, Trade. Everybody needs to be involved in the process. So we don't have something very specific to share with you at the moment, except to say it is an issue that's very much on our radar. We do take part in the necessary global forums and here with our local World Health Organization, and there's a huge amount of work to do. Monsieur, if it's Gruffat, I think, the use of COVAX as a mechanism. So we had good experiences and some difficulties. Clearly, this was a first time. So I think on the Honourable Deputy Minister's slides, he did show some of the pros and the cons of our experiences in this space. But just to say that COVAX got going relatively slowly. So by the time we were able to benefit from it, we had already got into the global fight, if you like, around accessing vaccines directly from suppliers and competing with developed countries. And that's partly because South Africa is not one of the 93 countries and territories that falls within the direct beneficiaries of COVAX. But obviously we're glad that we are able to participate. We have had direct purchases from COVAX because we purchase off COVAX, it's not all donations. And we have had COVAX being used as the channel for bilateral donations to us. And I must thank the colleagues that we work with in COVAX for their flexibility, support and assistance in getting that vaccine into the country. In fact, as late as last night, we were talking about pediatric mRNA vaccine as well, Pfizer vaccine, as part of our last outstanding commitment in our COVAX agreement. So we could possibly outline in more detail what the pros and the cons have been. It is a mechanism that we would support going forward, but obviously it's been a learning curve and there's quite a lot more that we could learn from it. I'm afraid I don't work in the space with the World Trade Organization, so I'm not comfortable to answer the question on any exceptions in that space, but we can get it in writing. We can get back to you on that. So we have, in terms of diagnostics and therapeutics, in terms of diagnostics, we are very strong in South Africa, largely because of the capacity that's been built over many years in support of our HIV program. It's a massive program. It's viral, so the viral capabilities for sequencing and for management of laboratories, PCRs, and a whole range of other tests is good. We have a national laboratory service in the public service which accounts for about 2/3 of all the laboratory capability in the country. And we have 3 other major private laboratory companies who have all linked with us during this time. So the diagnostic capabilities are good. We're very strong in our country. And we are also very proud that our network in at least the Southern African development community in the genetic sequencing space and our reporting from that network into GISAID is very good. And I heard comments made about perhaps poor treatment of us during the time when we revealed to the world that what we were seeing with Omicron. It's because we are able to detect very quickly, and the laboratories report, I'm the key point of contact in our government department when we see strange things in that space. So I hear on a day-to-day basis what is happening in the gene sequencing, specifically for COVID, but also for other diagnostic changes that are taking place. As far as therapy is concerned, well, I think we all went on a learning curve about ventilating and then not ventilating and how to manage oxygen. And so that was our biggest challenge, was how to get oxygen in large quantities, high volume, into very rural areas with poor roads, to develop big tankers into bulk tank supplies, and then to move our cylinder oxygen around. But we had a lot of cooperation from the private sector because we use about half of the country's oxygen in manufacturing, not in healthcare. And the quality of the oxygen in that environment is very good. So they were able to shut down the aluminium smelters and redirect that oxygen for us. So that was, in the early days, that was a very big plus for us in the country, a lot of hard work. But then the rest of the therapeutics, we have, we call it an HTA, a Health Technology Assessment type of committee, or a range of committees. We have a vaccine ministerial advisory committee that are looking at the evidence from both South Africa and around the world on clinical trials. We have a very competent regulator who works with a number of other reliance regulators, including the European regulator. So we are comfortable in this space, except, of course, that we have to import the therapeutics, and we purchase on the open market, not in any protected environment. And I think I've referred to that already. Very interesting questions about vaccination rates and what we are seeing in terms of illness. So we have vaccinated only 35% of our adults, of our total population, and we have not managed to really get to people under the age of 18 effectively. And certainly not, at the moment, we don't vaccinate children under the age of 12. So there's a large portion of our population who's either not been the target of vaccination or is poorly vaccinated. But adults are actually reasonably well vaccinated. And we think the strength in keeping people out of hospital is that we learned that the vaccines don't necessarily protect transmission. In fact, they don't protect transmission. But what they do is they protect against severe illness. And so by targeting the older population, primarily we hit the population over the age of 60 together with our healthcare workers in the beginning. And then we rolled down to 50 to 59, and then from 35 to 49. And our coverage amongst the population over the age of 60 is over 70%. And our population between 50 and 60 is sitting at 68%. So we think that that is probably what protected older people from getting sick and reducing the number of deaths from what it could have been. But I think that what we now know is that the virus was spreading in the relatively healthy population who didn't show significant signs of serious illness, but they were getting wild virus infection and developing immunity. So we have a complex immunological position where we have the population who have mixes of vaccine immunity, including a reasonable proportion who have had boosters and have probably got some cellular immunity, but a lot of people who got immunity from wild virus infections. And it's sitting as high as 95% of the population it shows antibodies on random testing. So perhaps that's why.
Okay. Mr. Can you wrap up, because there are other questions? Sorry for that.
Okay, sure. Okay, so the COVID vaccine and the impact on the health and the economy, I think that's a very complicated and long question, and I've sort of tried to respond to the fact that we've got a lot of work to do to catch up on our HIV. So let me, Madam Chair, let me stop there and take the other questions.
Thank you very much. Meneer Roos.
Thank you, Chair. And welcome, Mr. Crisp, and thank you for replacing Deputy Health Minister Dlomo. South Africa is known for the Omicron variant. Your compatriot, Dr. Angelique Coetzee, was the first to discover the new variant in November 2021. Several European countries reacted hysterically with new COVID restrictions and travel restrictions for flights from South Africa. In the Netherlands, even a new lockdown was implemented, not only ruining another Christmas, but also small businesses and people's lives. For what? Mrs. Coetzee told the world in an interview that the illness of this Omicron variant was very mild, based on the WHO definitions of what a mild illness is. She also said that scientists and politicians from all over the world have put pressure on her not to talk about the fact that this new variant causes very mild symptoms. She said, and I quote, "It is a minor illness," and my answer to that all along was, so what is it? Look at the WHO definitions of what is a light disease. If you do not like it, then you have to change the definition, but I cannot go out there and say it's a very serious illness. At one point I said that in Africa it's a mild illness, but in Europe it's a serious illness because politicians want me to say it. End of quote. My question is, did you also feel pressure from the European Union or the EU member states to present the illness of the Omicron variant as more severe than it really was? If yes, how much, by who, and how did that go? Thank you very much.
Thank you very much. Mr. Sinčić.
Thank you very much, Madam Chair. My question is similar to my question yesterday to the Ministry of Health of South Africa. So I had an opportunity to speak with physicians, doctors from South Africa, and they told me that they use early treatments to treat their patients. And these treatments, if they are given in correct doses and early in disease process, they are quite effective. So most notably, they were speaking about hydroxychloroquine and ivermectin, but also other cures that they used. So what is the official position of the ministry regarding these early treatments? Did you recognize these treatments? Did you ban or support some of these medicines? And what is the role of these early treatments in addressing COVID in South Africa in general? Thank you.
Thank you very much. From Davy, the Vice Chair, Mrs. Hersberger-Fofana.
Chers collègues, colleagues, Mr. Crisp, on behalf of the Committee on Development, I would like to thank you for this debate on the COVID crisis in the Global South, in particular in South Africa. I'm keen to hear about how you managed the pandemic and your view on action taken by the international community. We know that your country was hard hit by COVID. Access to vaccines in the Global South was a cause of great concern. So clearly we need to draw lessons from how the international community responded, in particular the European Union. so that we can ensure fair access to affordable vaccines in future, particularly for the most vulnerable in developing countries. My committee closely followed the EU response here, in particular the significant sums earmarked for the COVAX programme. We welcomed announcements after a summit between the EU and the African Union in February 2022. We will follow up on those commitments to ensure fair, equitable access to vaccines. We support sovereignty on health issues for Africa and the issue on production of vaccines in Africa. IPR waivers for the pharmaceutical industry was something that arose as a major issue. So what was your assessment of intellectual property rights? What impact did it have on your country and in general in the Southern Hemisphere countries when it comes to managing the crisis and the ability of the authorities to take countermeasures throughout the course of the pandemic? Thank you.
Thank you again, Madam Chair. Dear Mr. Cripps, I would also welcome you in our committee, and I'm very glad that we are here to understand your perception. We only know that we are facing a paradox. As while we have a sufficient supply of vaccines compared to the demand, the vaccine remains low in many low and middle income countries. And I would like to know your perception. What is your take on how this can be improved? And the second question on the pandemic treaty, what is your government's view of the ongoing negotiation as well as your main objectives? Thank you very much.
Thank you very much. And finally, Mr. Shahi.
Thank you very much. Back in September, this committee had the opportunity to ask Mr. Balcel from Moderna some questions. One is about why the company decided not to collaborate with the mRNA transfer hub for South Africa. Can you explain how local development and production of the mRNA vaccines by the hub will help South Africa to better respond to outbreaks or other diseases? What step does it take to achieve such local productions, and what are the barriers? And now maybe another important question. You talked about the importance of companies sharing their finished drugs and vaccines. The mRNA struggles to get doses from Moderna and Pfizer to carry out competitive clinical studies. Pfizer's flat out refused to cooperate. Can you tell us more about this, and what steps should be taken to oblige companies to share doses? Those are my questions. Thank you, Chair.
Thank you very much. That was the last question. You have 10 minutes to answer all these questions. That should be manageable. Thank you very much. You have the floor. You have to put your micro on, Mr. Crisp.
My apologies. I received a message that the Honourable Deputy Minister, Dr. Dlomo, is back connected. He may not have a strong connection, but he would like to speak, and then he will say if he would like me to speak further. Thank you.
Mr. Minister, you're back.
Thank you very much. Yeah. No, thank you very much for these questions. I am going to speak just for 1 minute and hand over to Dr. Nicholas Crisp. In any event, when we as a minister and deputy minister present, we always ask him to lead and make all these responses on these technical questions. But let me just say I'm very grateful to see one of the member of parliament here that we are together with him physically in Italy, where he made a very important contribution on the mental health of our workforce post-COVID. I just wanted to say thank you very much. I will not be able to say all this, but yes, some of the processes that we are involved in our countries to build our own capacity, not only for us in the mRNA hub, not only for us as South Africa, but for Africa as a continent. I will then hand over to Dr. Nicholas Cripps, who will take us right to the end of the questions. I thank you very much for your invite to us. Thank you.
Thank you very much, Mr. Minister. And we are preparing a mission to South Africa next year in February, and I hope we can meet in person. That will be much easier. Mr. Crisp, for the final answers, please.
Okay, thank you very much, Madam Chair, and thank you, Honourable DM. Yeah, so maybe just to start off with a very brief answer to the question from Mr. Roos concerning statements made by Dr. Coetzee. Dr. Coetzee is a general practitioner in private practice in South Africa, and she was speaking in her personal capacity when she was interviewed. She was involved in some of the committees because we have sentinel practitioners around the country who are giving us an indication of what they are seeing in clinical practice. But we did indeed see much milder clinical cases throughout Omicron. All of the variants, from BA.1 right the way up to now with BA.5, the clinical picture that we are seeing is not as severe. Whether that is because of the virus or whether that's because there's more immunity in the community at this point during our fifth wave is something that we could debate for a long time, I'm sure. But we were under no pressure to change our statements, and what we reflected was fact. So, yeah, so the Omicron is still with us in our country. It is grumbling along. We are seeing about 9.5% of all PCR tests are currently positive, but people are not particularly ill with it. Yeah, so that's the position there. Then from Mr. Cynic on early treatments. So we did not officially sanction the treatment with ivermectin or with hydroxy at all as part of our schedules. The ivermectin was allowed through a particular regulatory mechanism for individual patients on prescription from their own practitioners. But I think we now understand it didn't make any difference. And in fact, we have had reported cases of liver toxicity because I don't think anybody ever understood what doses they were giving and how they were managing it. So it has not been something that is part of our official approach or our official regimen. And the clinicians and scientists who were advising us advised us that it's not part of our regimens. So our treatment right from the word go was steroids and oxygen, and postural therapy, and a range of CPAP, and in the beginning ventilation, and now less ventilation. So yeah, we don't use those medications. Ms. Herberger, is it Fofana? How we managed our pandemic. Well, I think we learned a lot of lessons. Part of the challenge was that, as with everybody, the environment's changing every day. There's new science every day, new vaccines, learning about the vaccines, new variants, trying to monitor what was happening in the spike protein and the distribution of the rest of the sequence and how that was affecting transmission. So we hope we managed it reasonably well and managed to keep deaths and severe illnesses to the minimum. But I think that there are a lot of things that we've learned that we could have done better. We fortunately had a very good cold chain. We were able to move vaccines around very quickly and effectively, and we were able to work together with a number of other government departments better than we had done prior to COVID, and those have been lessons we will take into the future. Perhaps the strength, as I mentioned before, was that our very divergent public-private health system came together better than anybody could ever have hoped, and that raises a lot of hope for us for the future in working together. In terms of the action from the international community, we received support, and we also received that very disappointing response at the time that Omicron was announced. We announced, so when the laboratory picked up Omicron, and it was the laboratory, not the practitioners who, despite what the media says about Dr. Coetzee, the lab in Botswana had already picked up that there was something, And that's part of the genomic surveillance network in our country. Within 12 hours of the identification of the sequence, the labs had informed me, I'd informed the minister had already had a meeting with the president, and we had already had a technical meeting where the scientists were able to present to the our minister, and deputy minister, the president, and a range of other ministers in the committee of ministers who was driving the process. So we were able to respond very quickly and inform our public what we were seeing. And obviously we were disappointed because we didn't see the logic of what the global community was doing. And I think in hindsight, the countries who did lock us out have apologized or made other statements, and all's well. We learn from these things and we hope we don't do them like that again. As far as fair access is concerned, well, that's our big fight, and that's our president has been fighting for us on many different forums. And we will continue to try and make sure that access to vaccines, to intellectual property, to work with our own vaccines and so on, and to medicines is improved. That's our position. So when we go into forums, and there was a question asked about the pandemic treaty, our position is that we want to see that treaty strengthened. We think it's different from the international health regulations and complementary to it, and that's always been our position, and I don't think there's been a secret in what we have taken into those forums. There should be more meetings in the next week or two anyway, where we will continue with that discussion and continue with our proposals on targeted amendments to the international health regulations. So we would like to be a player. We like to involve our colleagues in Africa through the Africa CDC and other forums that we have. And we need to work together as the globe to make sure that part of the world doesn't remain vulnerable and therefore create this island of vulnerability for everybody. So, I mean, I think that's the principles from which we are working. The paradox that we have at the moment is, look, it's disappointing. We in our country sit on millions of doses of vaccine in cold storage, and the public has lost interest. The reason they've lost interest is because they think that COVID is over. They don't listen to the messaging anymore. They don't believe that the vaccine is going to make any difference to them because there is already information in the public space about immunity, general immunity in the community. So it's most unfortunate, but I think the lesson is that we probably should be buying in small amounts on an ongoing basis and not all trying to stockpile and then sit with these vaccines that we can't use and nobody else wants. And we will take that into our lessons. As far as the hub and Afrigen and the barriers are concerned, look, I think we're not naive to the fact that there's business. But from a health department's perspective, our interest is in the health of the population, not on promoting the business of private companies or businesses. So we will obviously continue to fight for a situation where we are able to build the capacity so that we've got at least the foundation for other vaccines. And the mRNA is a good vehicle. It's not the only vehicle. So we want to have these various vehicles for different vaccines that we can very quickly modify should there be another pandemic with something different, whether it's viral or otherwise. So having that capability in these hubs, having storage capacity that we can scale up quickly to volume, not just for ourselves, but for the countries around us, is obviously good for the world. It's not just good for us. So if companies are willing to share information with us and be partners to that, of course we would value that. But the fact that companies did not necessarily want to cooperate with clinical trials has not been a real problem for us, because from government, we have given the researchers, both within our government institutions and universities and elsewhere, sizable donations of vaccines to enable them to do the necessary clinical trials and comparisons around boosters, around interactions of heterologous boosting, and so forth. So we will continue to do what we believe is right and in the interest of the public, for our country, for our region, and indeed in the global space. And I think I'll leave it there. Thank you very much, Madam Chair.
Thank you so much, Mr. Crisp, for stepping in an excellent way. I have to say, I think you more or less answered most of the questions, and the one that hasn't been answered or were too political, we will take on board again and submit them in writing. And as I said, we are organizing an important mission next year to South Africa, and I think that's also an occasion to go further on this very, very important discussion. We move now to point 9, and that is an exchange of view with Ms. Annabel Gonzalez, who is the Deputy Director General of the World Trade Organization. We have now the World Trade Organization and then the World Health Organization to conclude today, and also our pillar on the global perspective. Mrs. Annabel Gonzalez, we've been discussing the last today and yesterday many issues with regard, of course, to the WTO TRIPS flexibility provisions and the whole discussion around that, and the result that has been, the compromise that has been reached within MC12. So it is interesting to see your views on that, how that went on, but also to the future. There's a lot of discussion already in this committee on the pandemic treaty, and of course that is a negotiation that is more within the World Health Organization. But nonetheless, everything that relates to intellectual property rights, of course, is within your competences. Also very important is the question how to strengthen local vaccine manufacturing, investments in healthcare professionals and infrastructure in developing countries. So very happy to have you, and we're looking forward to your introduction. You have the floor, Mrs. Gonzalez. Can you press on the speak button, please? She's online. The speak button is down on the screen, the speak button. Yes. Hi, Mrs. Gonzalez. Happy to see you again.
Yes, thank you very much. Happy to see you again as well, and thank you very much for this invitation. I'm delighted to take part in the proceedings of this special committee on the COVID-19 pandemic. So this conversation is both timely and critical. It is important to look carefully and objectively at the response to the pandemic at the global, regional, and national levels, and to learn the hard lessons from this experience. At the very least, the response to future global health crises can then be more effective, more responsive, and more equitable. From the outset of the pandemic and building on an existing foundation of our close collaboration across the multilateral system, we in the WTO have sought to take a holistic approach and an integrated and inclusive approach grounded as far as possible on empirical data and the realities of practical experience. The international trading system was put to test in unprecedented ways, and while far from perfect and not immune from criticism, the experience of the pandemic demonstrated that the existence of open production and supply chains across borders is essential for an effective and equitable response. No country, not even the most prosperous, let alone the more vulnerable, can or should hope to be self-sufficient when it comes to access to critical medical supplies. We saw this in the initial rush to get access to personal protective equipment. We then saw it in the early period of vaccine production and distribution, when attempts to control or limit trade in key inputs and finished products not only proved to be self-defeating, but also exacerbated inequities and inefficiencies in access to this. Now, on the positive side of the ledger, we saw dramatic increases in trade flows of critical medical supplies. And this was visible in the data. In 2020, even as the value of global trade decreased by 7% as a result of the economic impact of pandemic lockdown, trade in medical products increased by 16%. We also saw an unprecedented process of development and distribution of vaccines, remarkable both in the diversity of vaccines candidates developed in a very short space of time and in the speed of international distribution, which was overall greatly assisted by such measures as trade facilitation, the reduction or elimination of tariffs, and a practical and collaborative approach to regulatory approval. There has never been any vaccination program anywhere near the COVID response in terms of speed and breadth of coverage. But as we know, vaccine distribution, especially in the critical early stages, was marked by gross inequities. Senior management at the WTO called out these inequities early on and worked hard on finding ways of resolving them in collaboration with a wide range of multilateral partners. Even today, despite continuing enormous efforts, the pattern of vaccination remains fundamentally uneven, with some populations receiving second or third booster shots, while in other countries the vaccination rates remain at a few percentage points, even with frontline health workers remaining largely unvaccinated. Now, the reasons for these positive developments and the reasons for the grave shortcomings are complex and multifaceted. There is no single identifiable factor and no single standalone solution. We need to consider all the diverse factors behind this outcome and how they interact with one another as the basis for developing sustainable and effective solutions to the obstacles and inequities we confronted, as well as reinforcing those elements that led to the successful innovation of and access to vaccines. And this is what WTO member governments did at the recent 12th Ministerial Conference. The Ministerial Declaration on the WTO response to the COVID-19 pandemic and preparedness for future pandemics, or simply the Pandemic Declaration, reviewed the full array of trade policy issues that have bearing on the pandemic response, and it set up a process of review and reflection at the intergovernmental level. I will not have time to deal with every aspect, but to give you an idea of its coverage, it addresses broader issues such as the development dimension, food security, technology transfer and transparency, as well as specific questions regarding intellectual property, regulatory cooperation, trade facilitation, export restrictions, tariff classifications, and trading services. Now, a separate document from the Ministerial Conference that I would like to draw your attention to is a report on the wide range of activities undertaken by the Secretariat of the WTO. This includes statistical, policy, and legal analysis, and technical assistance and policy support for our member governments. In short, while member governments called the shots for sure, the Secretariat worked long and hard to provide the necessary support. And for more detailed insights and analysis, I recommend this document. The third outcome from the June Ministerial is, of course, the decision on the TRIPS agreement, addressing in more detail the intellectual property dimension of the pandemic response. The decision has its roots in the proposal submitted by the governments of India and South Africa in October 2020 for a waiver of certain international obligations that WTO members have under the TRIPS agreement, as well as a later EU proposal which largely concentrated on clarifying options under the TRIPS agreement for governments to override patents in the public interest. I will not go into the full details and history of the ensuing processes, but this was the subject of a very extensive and very intensive debate both within the WTO and well beyond it, marked by a common resolve to overcome inequities, especially in access to vaccines, but marked differences over what was needed to achieve this in practice. What ultimately emerged was the result of discussions between members on potential intellectual property obstacles to vaccine production that had been identified. In a nutshell, the decision provides positive guidance on the issues that members had identified as potential obstacles posed by national IP systems. It also eases the rules to give greater scope for governments to take direct action to override patent rights. In particular, it confirms and clarifies the right of members to override patent rights through direct government authorization, making clear that there is a wider range of options for governments to exercise this entitlement in an expeditious and streamlined way. It provides for a targeted TRIPS waiver to streamline urgent production of vaccines for export and to facilitate the development of geographically more diverse production chains in regions which have limited vaccine production capacity so far. And it makes clear that the protection of clinical trial data need not impede production and supply of vaccines when authorized by governments in this way. Now, the practical implication of the decision depends on domestic and regional action in two senses. The decision facilitates and enables domestic and regional initiatives for diversified COVID-19 vaccine production and distribution. But its implementation must be related to specific plans to diversify vaccine production, including financing, establishing technical and production capacity, and addressing regulatory issues. Also, since IP rights are granted and administered at the domestic level, it requires domestic steps to be implemented. Implementation would be most effective if coordinated between like-minded and cooperating members, ideally as part of a regional initiative, and integrated with specific initiatives to develop, harness, and diversify vaccine production. Now, implementing the decision may have direct practical impact if integrated with regional plans to expand mRNA vaccine production capacity, whether or not such plans entail some form of partnership with technology originators. So the TRIPS decision foresees a further decision by members on its extension to COVID-19 therapeutics and diagnostics, with active negotiations currently underway, with a deadline set for December 17, 2022. So with that, let me stop here, and I'll be very glad to take any questions that you may have. Thank you, Madam Chair.
Thank you very much, Mrs. Gonzalez. And we now move to the questions. Mr. Kimporopoulos, please.
Thank you, Madam Chair. And I would like to thank you, Ms. Gonzalez, Deputy General, Deputy Director General, for being with us. Improving vaccine coverage globally is key in order to ensure a sustained recovery globally. In our view, this includes active support of an environment that allows setting up capacities for local vaccine manufacturing and strengthening preparedness, but also addressing all the bottlenecks and restrictions related to the production capacities, the availability of raw materials, and our supply chains. Have we done enough of that, and what can we do better in the future? Thank you very much.
Thank you very much. Mrs. Cerdas, please.
Thank you, Chair. In 1928, Alexander Fleming chose not to patent his discovery of penicillin, stating, "I did not invent penicillin." This antibiotic ended up saving more than 200 million lives and gave him the Nobel Prize. In 1920, a Canadian physician, a medical student, and a chemist began working on insulin, and in 1923, they sold the patent to the University of Toronto for $1 each, stating that insulin does not belong to us, it belongs to the world. That discovery saved more than 300 million lives worldwide and gave them the Nobel Prize. 6.5 million people have died of COVID-19 and more than 630 million confirmed cases have happened worldwide. The COVID-19 vaccines developed are safe and effective on avoiding deaths and severe disease by COVID-19. India and South Africa have proposed a TRIPS waiver back in October 2020. Should there be a mechanism for future pandemics to discuss these kind of decisions earlier on in pandemics in order to save as many lives as possible? Thank you.
Thank you very much. Mrs. Gonzalez for the answers.
So thank you very much for the questions. On the first question posed by Mr. Kimpouropoulos, I would say that several governments took very important measures to facilitate the distribution of vaccines. They took facilitation measures, for instance, on trade facilitation. I can remember right now the case of, for example, Brazil as one country doing that. They also, a number of members took action to facilitate regulatory cooperation, a key element in the context of importing vaccines. They also took action to facilitate the importation of inputs, for example, as I mentioned, sometimes eliminating tariffs on these inputs or on ancillary products. So we saw a number of measures that were geared in the direction of facilitating trade and addressing these bottlenecks. But clearly, there was also the adoption of export curbs, export bans or export restrictions by members, which particularly in the beginning of the pandemic made it very difficult to have equitable access to vaccines. So to your specific point, in thinking in particular about the future, and that is part of what the declaration on the pandemic aims at doing, there is the need to continue to streamline the importation of vaccines, but also to make sure that any restriction that is imposed on the exportation of vaccines is targeted and follows, timeliness and other elements that are included in the pandemic declaration. On the question by Ms. Cerdas, thank you very much as well. So one particular distinctive element of the TRIPS decision is the practical approach that it takes to the pandemic. It doesn't want to question the whole system that is already in place, but looks at addressing particular problems to be able to expedite the production, manufacturing, distribution of vaccines. The template that is considered in this decision is now applicable for the COVID-19 pandemic. But I would think that in going forward, if other pandemic were to strike, members could come back and look at this template and put it to good use as well. But that would be, again, a decision for WTO members to take. And if I may remind everyone, this is a decision that is taken by consensus by all WTO members.
Thank you very much. Mrs. Trillet-Lenoir.
Sorry, Chair. Thank you very much, Mrs. Gonzalez. First of all, I would like to congratulate you and remind my colleagues the major role played by WHO in access to vaccines against COVID-19. You have run your action far beyond the commercial considerations of your mandate. And this is a good thing and has, in my opinion, to be said. It is not perfect. Last June, the WHO negotiated an agreement which authorized developing countries to manufacture vaccines against COVID-19 without the authorization of the holders and for a 5-year period. However, this negotiation does not include medications against COVID-19, and I know that some colleagues here are very keen on medicines and also on tests. The WHO gave itself, together with its members, 6 months to decide on this extension, on more flexibility on treatments and diagnostic tools. I would really like to know what is the situation now for these products and how you see the outcome of the forthcoming negotiations at the end of the year. Can you share with us the various compromises on the table? And finally, can you tell us if your organization is associated with the development of the future international treaty on pandemics, particularly with regard to the sharing of IP in times of health crisis? Thank you.
Thank you very much. Mrs. D'Amato.
Thank you, President. I will speak in Italian. Okay, grazie alla signora.
I'd like to thank Madam Gonzalez for being here. As far as I'm concerned, the WTO responded too late to the pandemic with the TRIPS declaration, which covers vaccines and was adopted only in June 2022. And there's still no decision on this extension of the scope to therapeutic and diagnostics. So how can you say that the WTO response to a pandemic has a good scope? Because reaching January 2022, an end with a pandemic that started at the end of 2019, it's a bit too late. Now, the TRIPS was set up to protect human rights. The WTO and its member states recognize that human lives are more important than the economic rights of the owners. But in case of this emergency, we've looked at very complicated, weighty, difficult process that could not establish global measures on a wide scale, which are necessary to combat a pandemic, and these technologies require know-how and transfer, which are not included in the compulsory licenses. So do you think we should change something? Now, this is a rhetorical question, actually, because we'd have to change or modify trade law at the global level in order to respect or safeguard human lives. Now, the TRIPS waiver of 2019 was considered as was unjust and in favor of Western countries. And then there were countries that were excluded from the negotiations. And the process was criticized because it was used to bring pressure to bear on developing countries. How do you respond to these criticisms?
Ja, vielen Dank.
Thank you for this debate. My question follows on from what the previous speaker said. I believe that it is important to have patent protection, and I'm not the only one. We need huge investment in development of new medicines until they are ready to be marketed. When it comes to COVID vaccines, we saw the huge money invested, including taxpayers' money. There was a pressure on the general public to take up vaccines, and it turned the vaccines into a money-making endeavour for pharma companies. So why has the WTO refused a patent waiver for COVID? But there was no restriction on vaccines, no restricted supply. We had an oversupply. So now let me be clear. I want to hear your arguments on the specific point at which you took the decision on a patent waiver. Thank you.
Dankeschön. Mrs. Gonzalez, for the answers.
Thank you very much for all of the questions. Let me first refer to the question posed by Ms. Trillet-Lenoir on the ongoing negotiations in the area of therapeutics and diagnostics. So these negotiations are very actively underway. And this takes place at the level of WTO member governments, and the progress and possible outcomes are very much in their hands. That said, my impression is that governments across the spectrum are engaging actively and in good faith with the due sense of seriousness of purpose that the issue demands. The two themes that I have heard in particular in the context of these discussions are firstly the need to have a strong empirical or factual understanding of the current situation and the current challenges in relation to both therapeutics and diagnostics, including on issues of supply and demand. And second, the possible need to clarify to some extent the scope of therapeutics and diagnostics referred to, because these technological fields are by their very nature more diverse and less well defined than the field of vaccines. Members are engaged in these conversations, as I mentioned, and the expectation that the Director General, Dr. Ngozi Okonjo-Iweala, and myself have is that members will be able to come to an agreement by December 17, which is the date established in the TRIPS Declaration. Now, on the questions by Ms. Tamato, and I'm sorry I couldn't hear the name by the speaker that follow, refer to to elements that I think are related, which is the response of the WTO. Does it come, is it too little and too late? And, is there something else, and is it adequate really to enable developing countries to have sufficient access to the vaccines? I would like to maybe start by saying that the effectiveness of these TRIPS flexibilities depend entirely on the way they are used in domestic law, as they have no effect otherwise. And this explains why one of the key thrusts of the TRIPS Declaration, addressing directly some of the most commonly identified obstacles that governments reported in considering their use. And what is clear is that governments have a very wide range of scope, particularly in an emergency situation such as the pandemic, to directly override IP rights in the public interest, including without prior negotiation with the right holders. And this is something that can be found in many countries' laws already and is fully consistent with the TRIPS agreement. However, countries have reported hesitation both in terms of legal uncertainty and also political hesitation. So the TRIPS declaration addresses both of these points directly. There is also one more technical constraint on these flexibilities when it comes to production, especially for export. And under the amended TRIPS agreement, this is normally structured as a response to the needs identified by importing countries. So what the TRIPS declaration does, in view of the nature of the pandemic, is to turn this around and provide for an immediate, supply-driven approach that can anticipate and prepare for the needs of importing countries as well as international humanitarian initiatives, so as to streamline and facilitate an urgent pandemic response when needed. Now, should this have been agreed earlier? Perhaps. Perhaps. But again, let me remind you that decisions in the WTO are taken by consensus among 164 member countries. So it was when these members were ready to find the agreement that the TRIPS declaration decision was finally taken.
Thank you very much. Mrs. de la Pisa.
Muchas gracias, Presidente. Thank you, and thank you, Madam Gonzalez. Well, you have a lot of in trade and development. So I'd like to know from you, what could the impact be on the market of a massive buying of vaccines? What was the effect on the market of the Commission's purchase of mass vaccines, and what is the difference if it's a moment of urgency or a moment of stability? Because a measure can be useful if there's an emergency, but what if it becomes a common practice? How does it influence free competition or the arrival of new types of treatment? Then again, why do we limit ourselves as being concerned on the vaccine market when I'd like to remind you that the fear at the beginning were the message for personal protection or respirators, ventilators, and the capacity of hospitals, because it's not just a question of managing vaccines and getting to everyone, and yet we have the possibility of set up camp hospitals to improve our hospital capacity. So I want to know, why are we only concerned with one type of behavior when dealing with a pandemic? Thank you.
Thank you very much. Mrs. Konečná.
Děkuji, paní předsedkyně. Mluvit česky. Já myslím, že...
Thank you. I'll be speaking Czech. Thank you, Ms. Gonzalez, for joining us this morning. We haven't heard replies to our questions, though, so let me try again. I am bothered by the negotiating process. The green box negotiations, if you like, it has been described as unfair advantages for Western countries only. So what lessons do you plan to learn? You haven't replied some of our colleagues' questions. The response to the pandemic was very complex. What about therapeutics and diagnostics? I believe that this was all left too late and then reduced. So what lessons have you learned to gear up better for the next pandemic? We need to have a more responsible approach there. We saw a lot going on behind closed doors, and what we haven't heard yet is what will change in future. You talked about the past, but what will you be doing in the next 2 to 3 years to ensure greater transparency, more timely decisions, and true protection of human lives? Thank you.
Mrs. Donato, do you want to raise a question? You can.
After, for the WTO.
Okay, but not, you don't, okay, very good. Mrs. Gonzalez, please.
Thank you very much for the questions. On the points raised by Mrs. de la Pisa, let me say a few things. In the face of an unprecedented crisis like the pandemic, I think the world confronted 3 very important challenges. The first one was to develop a vaccine that would be effective, would provide effective protection against COVID-19. The second one would be, how do you ramp up production? How do you ramp up manufacturing as quickly as possible to produce as many vaccines as possible? And the third one is, how would you go about the distribution of the vaccine so that everyone around the world could have access to it? On the first challenge, I think that science responded to the world, and the vaccine was developed at an unprecedented speed. We have never seen anything of the sort. Clinical trials, clinical trials were done very rapidly, expeditiously approved by the authorities. So this part was really a very impressive response to the pandemic. On the manufacturing and the ramp up, this is also that, with a time lag, and this is an important element of it, because you cannot go from no manufacturing to manufacturing all the doses of vaccines that were needed to protect against the virus. On the ramp up, companies responded relatively quickly, but there was a time lag. Which is, again, if you think about it, sort of part of the fact that you went from no production to having to produce something for everyone in the world. And the third element of it, the distribution part, is where trade came to play a very important role, because as we know, vaccines were produced only in some parts, in some countries, in some regions, but we needed to cover the whole world. So the only way that this could be done was through trade. And this is why measures like trade facilitation, expedited customs procedures, regulatory cooperation, and others were critical in doing so. The adoption of certain measures, like export bans, restricted access to vaccines. And it was not so much, in the case of the vaccines against COVID-19, it was not so much an issue of pricing. It was more an issue of equitable access to the vaccines. Over time, their supply has exceeded demand at this point in time. But the lesson that was developed from the pandemic is the importance of having diversified manufacturing capacity of the vaccines. Because the problem is that if production is concentrated in a few countries, and those countries establish export curbs, then it will not be possible, even if the resources are available, it will not be possible to access the vaccines. And this is why instances that aim at diversifying capacity, for instance, in the African continent, are so important. Now, the response that is provided by the TRIPS decision is a response that is targeted to address those problems that were specifically and pragmatically identified by India, by South Africa, and by all the countries that were demanding a solution in this particular area. So in a way, it's a very pragmatic response. Now, it is an instrument that member governments have at their disposal. It is not the whole part of the solution, because as I mentioned in my initial statement, this would need to work in tandem with other elements as important as having a business plan, a business model, having financing options, having the necessary skills to produce the vaccines, and other elements. So this is why this is not only an issue of intellectual property flexibilities and the targeted waiver for exporting vaccines, but it's also really part of a broader ecosystem that needs to be in place in order to be able to produce, to diversify manufacturing capacity. Now, in terms of whether the process was unfair or whether it is biased in favor of advanced countries and Western countries, what I can tell you is that discussions here at the WTO were very intense at different levels. At the first moment, it was negotiations taking place among four major stakeholders: India, South Africa, the European Union, and the United States. Then those negotiations expanded to bring in the rest of the membership. And there were many other countries who were very active in these negotiations. This included African countries represented by their coordinators. This included countries like Brazil, Mexico, Argentina, China, Thailand, and other countries across the world. And this is how, at the end of the day, for the decision to be adopted in the way in which the WTO works, it needs the consensus of all of its members, of all of its 164 members. And this happened in the context of the 12th Ministerial Conference that was held that last June. So I will respectfully push back on the notion that this is an unfair process or that this is something that is biased against developing countries. Because if developing countries would have felt this way, they would not have agreed to the outcome that resulted in the TRIPS decision. Now, as was rightly stated, the decision is the scope of the decision is pandemics, is vaccines. However, paragraph 8 of the decision specifically establishes that members will decide on the extension of the decision for therapeutics and diagnostics no later than 6 months after the adoption of the decision, which brings us to mid-December. So right now, members are in the process of discussing. As was the case originally with vaccines, there are different views about these issues among the membership. And as I said, two very important issues that are coming out in the context of the discussion relate first to what are the conditions of supply and demand right now? What are the conditions that would require an extension of this TRIPS decision to cover vaccines and therapeutics? And the other question is, what exactly do we mean when we talk about therapeutics and diagnostics? And these are questions that are being actively debated at this moment in the context of the WTO. And I would not like to prejudge the outcome of this decision, but just to say that this is something that is being taken very seriously by the WTO members in accordance with the importance that it has.
Thank you very much, Mrs. Gonzalez. I have final two questions for you, one about the past and one about the future. About the past, I go back to really the start of the pandemic. And I think we all remember as if it was yesterday. In Europe and also in the rest of the world, we didn't have any protective material. We had none. Not to protect the population, but also not to protect our healthcare workers, for instance, in hospitals, in elderly homes, and so on. We discovered that we didn't have a clue how the value chain of this medical equipment looked like. We didn't have a clue how the trade flows went. And we discovered that, for instance, on masks, we were 90% dependent on China. Did the WTO draw lessons on these facts in the beginning of the pandemic? Because, of course, we can now organize ourselves on that sort of protective material, but we don't know how the next pandemia will look like and what we will need at that stage. So do we organize ourselves, and what is the role of the WTO to have a good overview on these trade flows and supply chains? On the future, many questions has also been risen by members on, of course, intellectual property rights, but also the pandemic treaty. My question is, what is a very specific, how will the WTO organize itself on that discussion on the pandemic treaty in terms of procedures? I don't have a clue. How will that work? Thank you. You have the floor.
Thank you very much, Ms. Van Brent, for your questions. I think from the past, one very important lesson that we have learned is precisely the one that you alluded to, which is the importance of monitoring supply chains in this area to understand how is trade flowing and where are the choke points. This is something that we did in the context of this pandemic, and working very closely with the manufacturers to try to understand how the supply chains work and to try to identify the bottlenecks. And we actually produced a note that identifies all the bottlenecks that impacted the operation of the supply chain, because it was not only export curves that impacted at some moments of the pandemic. It impacted different products, but it was really about customs officials, for example, not even knowing what were the critical inputs that went into a vaccine, and not knowing, for example, how to classify those inputs. So we produced a series of technical notes identifying, for example, the inputs that go into making vaccines, identifying what were some of the obstacles that were present on the regulatory front or on the customs front, and others. And I think one lesson that is very well learned is the importance of monitoring and transparency in making sure that trade can continue to flow, particularly in the context of the pandemic. So increased monitoring is definitely one important lesson from the pandemic. And on your second question, the WTO has been invited to submit its views to the ongoing negotiations in the WHO on the pandemic treaty. We are also observers in those negotiations, and of course it is very important for members to bring consistency in their positions in both organizations, in the WHO and in the WTO. But we are, from the perspective of the WTO Secretariat, we work very closely with the WHO, and we convey our views, which are mostly based on these documents that I made reference to, on the pandemic declaration, on the TRIPS decision, and on this note that the Secretariat produced on the different ways in which the Secretariat has supported members in the fight against the pandemic.
Okay, thank you very much, Mrs. Gonzalez. That was very clear. Thank you for being here, for answering our questions. And we move on now to our last but not least point. That is an exchange of view with Dr. Ryan, who's the Executive Director of the Health Emergency Program of the World Health Organization. Dr. Ryan, we're very happy that you can join us. I don't have to make a lengthy introduction. I think if many people in the public opinion has never heard of the World Health Organization before the pandemic, that must have dramatically changed in course of the last years. And during that pandemic, you were in the core of that crisis, having been responsible for the world health. And I think it's important that you give us an insight on the main lessons learned. I'm quite sure that within the World Health Organizations, you made lengthy assessments on how that pandemic evolved, what the role was and should be, what went good, what went wrong when it comes to the responsibility of the World Health Organization, how you look at COVAX, but how do you look also at what happened within the European Union, the responsibilities in the European Union, and the relationship. And of course, also, how do you look at the future, being also responsible for the pandemic treaty? Mr. Ryan, Dr. Ryan, sorry, I give you the floor to give your introductory remarks, and then we go to the questions. You have the floor.
Thank you very much. Can you hear me there?
Yes, we can hear and see you. Thank you very much.
Okay. Thank you very, very much. And I'd just like to thank the European Parliament Special Committee on COVID-19, and particularly you as Chair, for the invitation to speak and the opportunity to have an exchange with the members of the committee. Also to congratulate the Special Committee's work, in particular for the focus on this lessons learned exercise and and recommendations for the future. We must learn from this pandemic as we must learn from all crises. And this is, I think, the right moment to exchange views with relevant stakeholders and see where we go from here with so much going on right now globally around governance, financing, systems, tools, workforce for the future, how we will govern, finance and deliver on pandemic preparedness in the future and health emergency preparedness. It's really important that we make these commitments and have these discussions before the current pandemic ends. I'm pleased I can't see everyone there, but I'm sure some of you, we met first in Geneva during the 75th World Health Assembly, and we've already had a fruitful discussion at that time, and I hope this discussion today will further contribute to that. Our thanks to Team Europe for the global pandemic response and your support to WHO. I think overall Team Europe has delivered huge amounts of euros, so I think over 47 billion euros to help its partners to address the pandemic and its consequences, which is a vast amount of support. Actually through Team Europe, I think the EU and the member states have played a leading role in the fight against the pandemic. There's been a strong partnership between the EU and WHO in support of our common ambitions for health across a much wider area than COVID, and we just acknowledge that the European Union is the largest voluntary contributor of funds to WHO in both 2021 and 22-23. So all of this partnership is leading to...
Sorry, Dr. Ryan, can you, because you're too close to the camera and then the interpreters cannot see your mouth to interpret. That is much better. Thank you very much. Thank you.
And it's a strange Zoom. Normally, I'm in the perfect place when I sit close to the desk. Is that okay now?
This is perfect. Thank you very much.
Okay. Good. So this partnership is very deep, and for stronger health systems, universal health coverage, access to medicines, response to emergencies, prevention and control of antimicrobial resistance, driving a One Health approach to global challenges. I think the EU and WHO are very aligned on what are the key priorities going forward, and particularly in the areas of the health impact of climate change, with COP27 coming up. I'm sure you're watching the various reports that are coming out at the moment, and the situation is very fraught and very dangerous right now. And how are we going to help countries to make their environments healthier, help their populations, improve sexual and reproductive health, and keep at bay communicable and non-communicable diseases? So, in a sense, the pandemic has demonstrated that health and health access and access to health products is absolutely fundamental to achieving our goals within the SDGs, and absolutely fundamental to protecting our population against future pandemics. But it also highlighted the need for a strong, coordinated, multilateral international response. When that was present, we did well. When that was not so present, we behaved in ways that didn't drive a coherent response. And we must learn how to further enhance those cooperative instincts, those partnership instincts, and build the systems that build off that strong base. There was a crucial role played by government, by leaders in political system, by parliaments and parliamentary platforms that have enabled partnerships, enabled engagement with civil society, have built trust with communities, and we need to focus on the role of parliaments at all levels in doing that. And we are putting a lot of focus in our activities on engagement with parliaments, and we'll soon finalise our first WHO strategy on parliamentary engagement. You had sent forward a number of questions very specifically to us. I will try and address those in my remarks, but I'm sure there may be follow-up questions. I'm also joined online by Kate O'Brien, who's our Director of Immunisation, Vaccines and Biologics, IVB, and Kate has been absolutely central and a huge leader in the whole space of vaccination against COVID and the whole COVAX initiative, and she will be online to join me to answer any questions after. You did put some questions on the IP waivers and TRIPS. You know that the objectives and principles of the TRIPS agreement, it protects the intellectual property, but should contribute to the promotion of innovation and to the transfer and dissemination of technology to mutual advantage. in a manner conducive of social and economic welfare, and to balance those rights and obligations. That's a difficult balance. The TRIPS agreement allows members to formulate their own laws and regulations and to adopt measures to provide necessary public health protection and to promote public interest in sectors of vital importance to their socio-economic and technological development. This was precisely the intention of the original TRIPS waiver presented by several countries. The ministerial TRIPS decision is a first step in the right direction, but with a more limited waiver. I think it's important that we need to build the incentives for the development of vaccines and continue to do so. We also need to recognise that the vast amount of this investment is coming from public sources, taxpayers' money being used to develop these products, and as such, the issue cannot only be driven by the intellectual property rights of the private sector. We can discuss that further if you so wish. You asked some questions about the lessons we've learned from COVAX, and Kate will be here to answer any further questions or make further comments in a little while. COVAX has delivered nearly 1.9 billion doses of COVID to 146 countries since the start of the programme. It has been key to addressing global vaccine inequity, delivering over 75% of vaccine doses to low-income countries. In other words, if you live in a low-income country, there's a 3 out of 4 chance that the vaccine you got came from COVAX. And this includes 350 million doses that have been shipped by COVAX of the 407 million doses shared by the EU countries. More than 40 countries were only able to start their realisation programmes as a result of COVAX. So in terms of learning, we are learning more and more that equitable access requires end-to-end solutions that centre on public health and the need of the most vulnerable being considered at every step. It cannot just be at the last step in terms of distribution and equity. Hoarding, export restrictions and nationalism can be expected. All governments are primarily accountable to their own people for their protection. So we need to build the institutional models in advance for sharing and partnership, where governments collectively can pursue the best benefit to all by vaccinating. In this case, COVID would have been vaccinating some people in all countries in order to reduce the death burden in those most vulnerable. And we need to find better ways of bringing that together in advance. A successful pandemic response also involves taking risks in the sense of financial and political risks in order to advance the common good. And in that sense, COVAX was able to draw on huge experience within the partner institutions and leading global health organisations that are trusted pioneers in their area of expertise. So this way, COVAX built on existing operational capabilities. It was remarkable to see, the heads of agencies coming together day after day, week after week, and all of their work and all of their staff working together to really fight to get this vaccine to all corners of the planet. Was really the application of global regulatory standards, labelling, barcoding, all of the things that had to be done in order to deliver this were remarkable. The collaboration worked well. Meeting country demand actually went well once we had enough available doses. We supported country readiness and delivery and systematically tried to improve the country's capability to deliver the vaccines down to the last mile. There have been several challenges, certainly in terms of delivering the doses in 2021, disruptions in the vaccine supply, unpredictability of supply in the longer term. Now we've got ample supplies, but getting shots into arms has become even more critical. The early political support provided and the financial commitment to the facility meant that critical investments in R&D and manufacturing were able to be made, but not enough to be able to capture the necessary proportion of the market. In terms of the future, there's lots to be talked about the models for future collaboration, for future access to countermeasures. We have the COVAX example, we have the PIP example in influenza, we have the ICG examples for Ebola, meningitis, yellow fever and cholera. We have many global mechanisms. We now need to move forward and consider in advance of the next pandemic, what are the best platforms, for us to prepare. I think there was also a question on the key elements of a European strategy for lower and middle income countries. I think it helps the EU when you have a mechanism like COVAX that can coordinate the supplies to countries. It reduces the administrative burden for low and middle income countries. I think the EU should really look at reducing or removing earmarking of doses for specific countries. And obviously, the EU, as a leader in working through mechanisms like COVAX, to prioritise financing of doses purchased through such a mechanism. In terms of One Health, there was another question that was asked on the One Health high-level panel. There's a lot of work going on inside WHO and now within the quadripartite with FAO, OIE and UNEP, looking at One Health, looking at particularly the animal-human interface and the threat of emerging zoonoses and the particularly risky points on that animal-human interface. There's a lot of work been done by the One Health panel on a theory of change, a framework designed to guide and provide priorities for the organisations aforementioned. We've got a lot of work to do on implementing the advice and recommendations of the One Health panel, but we also have other panels, the Scientific Advisory Group on Origins, we have a Strategic and Technical Advisory Group on Infectious Hazards. So we have many, many groups who are working in this space right now, helping the Secretariat here in WHO, inputting to Member States, and really trying to design a future in which One Health is at the centre of everything we do, both in terms of risk management, risk reduction, surveillance, and I believe that we're on a pathway now to taking a much more fundamentally integrated approach to One Health. The One Health panel are now developing a white paper on definitions of prevention and many other things, which will be presented to the Secretariat of Member States in due course. You also asked some questions on the pandemic treaty. First of all, thanks to the European Union for your leadership in driving the discussions and negotiations on a WHO convention or agreement or other international instrument in a member state-led process under the intergovernmental negotiating body, which continues to work very hard on this. It is for our member states, it is for you to decide what such a treaty should contain. We believe that this could be a groundbreaking generational change in the way we do business at global level in terms of pandemic preparedness for the future and health emergency preparedness. We need to continue to build the governance, the financing, the systems, the tools and the workforce, the access to countermeasures that are going to be needed in any future pandemic. Doing that without a clear high-level agreement on how that is to be done, a treaty binding everybody to a set of behaviours, a set of commitments, a set of interactions that will guide us and make us more successful in a truly interconnected global system for public health surveillance, public health preparedness, public health response and recovery. I think that's it. There was some question on trips again, but I think I've referred to that in my previous input. So sorry I was just trying there to get as much response up front to the questions that we were provided with. So I'll hand back to you.
Thank you very much. We move to the questions then after your introduction, Mr. Kimperopoulos.
Thank you once again. And I would like to thank the Executive Director, Mr. Jan, for being with us today. I will be brief. Having strengthened global health architecture with a reinforced WHO at the center is fundamental in order to improve our pandemic preparedness and increase our emergency surveillance. In this regard, how do you see the role of the WHO in the post-COVID era? Is it reinforced or not? And how do you assess the response during the first stages of the pandemic? Would you do something differently? But the pandemic also shed a light upon the importance of mental health. And therefore, I wanted to know, how do you mainstream mental health within your work on health emergencies? Thank you.
Thank you very much. Let me also raise a few questions. It's now 2.5 years that we know this virus, that we got acquainted with it, but we still do not actually know what the origin is. Does the World Health Organization has a view on that, or a beginning of a view on that? Also, on the past and on the beginning of the pandemic, in the beginning, China downplayed the severity of the virus and the effect it's had on the health of people. Did the World Health Organization adequately address that with China, and how can we make sure next time we can solve that problem? And it also connects to a suggestion and PAHO yesterday made when we had a discussion with them. They mentioned that many countries did not comply with the international health regulation, and so that there were problems over there. And they suggested that we should strengthen the international health regulation by introducing sanctions. A last question is the technical hub was most of the time, the medicine patent pool, was empty for most of the pandemic, and ACTA A has been widely regarded as a failure. Do you look at it the same way? Does the World Health Organization look at it the same way? And what should we do to ensure that it doesn't happen next time around? You have the floor, Dr. Ryan. Dr. Ryan, press the speak button, please.
I did already. Okay.
Oh, yeah. Sometimes it's
Sometimes it takes two clicks. In terms of speaking the role of WHO, and I think maybe to take a step back, there's a perception that in some way WHO is a building in Geneva. We're a secretariat, and I'm sure you feel the same thing in the European Union. We're a secretariat to 194 member states. Our job is to implement their will through the resolutions that they put in place, through the regulations that they agree, through the accords and conventions that they agree under the WHO Constitution. So our job, do I see a role for WHO moving forward? Absolutely, because WHO has 194 member states. We are now in a world deeply threatened by increasing epidemics, increasing health crises. For the first time ever, we have over 50 graded emergencies at WHO for which we're providing international response at the same time. COVID is just one, counted as one in that. We are seeing a deep intertwining of health, climate, conflict, vulnerability, injustice, lack of access to healthcare. And these are self-amplifying in places like the Sahel, the Horn of Africa, Middle East, in Africa and and everywhere. We're seeing an increase in the risk of epidemic disease. We're seeing huge pressure in our environment. We're seeing breaches of the animal-human species barrier. We're seeing amplification of disease and unsafe healthcare facilities. We're seeing dissemination of disease around the world. And all of that's not because of viruses. That's not because of the microbes. That's because of human behavior. That's because of human exploitation. It's because of human greed. It's because we are using up the resources on this planet, and we have created a fragile planet, a disrupted ecosystem in association with that planet, and we are leaving billions of people behind in destitution without adequate access to healthcare, to life or livelihood. That is what we've set up. That is all driven by human endeavour. We talk about human innovation and human science and our ability to create all of these solutions, but we're creating solutions for problems that are essentially 100% man-made, person-made problems. So in that sense, do I see a role for the World Health Organization as an alliance of 194 member states? Absolutely. Without that World Health Organization, what are we going to do? Where are we going to be? Is each individual country, is each individual regional bloc going to come up with their own global solutions for a completely disrupted ecosystem, for a highly vulnerable population around the world, where the people of the South are paying the deaths of the people of the North, the climate deaths of the people of the North. Something has to give, something has to change. And I do believe, personally, that the World Health Organization is a fantastic platform to do that on. Like all organizations, like all secretariat, we must evolve, we must improve, we must provide better services to our member states, but it is ultimately for our member states to do that. The questioner asked about mental health, very, very important issue. In relation to COVID, we've seen tremendous pressure on people, ordinary people, on health workers. We've seen anxiety, we've seen post-traumatic stress disorder in health workers, and that's only dealing with the direct impacts of COVID-19 on mental health. We have a global mental health crisis, and mainstreaming mental health into universal health access, mainstreaming mental health services into our primary healthcare services, making sure that people have access to diagnosis, to support, to preventive measures is absolutely essential to achieving the Sustainable Development Goals. There is no point bringing a population of 7.5 billion people to physical health if their mental health is at risk. And the definition of health by WHO is very clear from going back to Alma Ata in terms of the state of physical and mental well-being. So I don't think it's been done enough yet. I don't think mental health has been mainstreamed enough anywhere yet, at local, national, or at global level. So I hear you in calling for that mainstream of mental health into the system. In terms of disease origins, we have a scientific advisory group on origins that's been working over the last year, looking at the evidence, the scientific evidence for disease origins. We know there are a number of different hypotheses for the origin of SARS-CoV-2. All of those hypotheses still remain on the table. The SAGO met last, I believe, in Thailand last week, and continue to meet to advance the scientific understanding of the origins of the disease. But no, to answer your question, we do not specifically understand the specific proximal origin of the virus. What we do know is that the virus emerged in humans in Wuhan in China, and it is working back from that initial clusters of disease that we need to be able to understand what the origins was. But we do know that the likely origin of the virus was in a small mammal or bat, but the route by which that virus got into humans is in question and still remains under investigation. And with regards to the initial reporting of the disease, the syndrome at the time that was not obviously recognised as SARS-CoV-2 or COVID, the WHO responded immediately to the first signals of an unusual disease in Wuhan and engaged very robustly with colleagues in China around getting access to information, getting access to the field, and it is something that we need to continue to work on with our member states. And it's not just one member state. Many member states when a disease is beginning and starting to spread within a country, there is a lot of local and national concern. Getting full transparency at a global level is something that we struggle with in many situations. And right now, I've just come from a meeting of the states parties to the international health regulations. We're meeting right now with the IHR Review Committee, and they're actually actively considering a whole set of amendments, potential amendments and adjustments to the IHR based on the experience of COVID and other epidemics. Again, it's for the member states to decide the extent to which the IHR should be changed and the extent to which any sanctions should be introduced into the IHR process. We wait for their deliberations on that, and as I say, there's an active process underway to do that. In terms of Act A, I would disagree with you in the sense that characterising Act A as a failure. I believe personally that the organisations that came together in Act A came together to try and solve a massive problem in the midst of tremendous hoarding, greed and difficulty, where individual states and individual country groupings were not willing necessarily to share all the benefits that came from the products that were emerging. And I do believe that the ACT Accelerator and COVAX in particular provided an absolutely vital lifeline for the provision of vaccines to particularly to low-income countries and low and middle-income countries. The fact that organisations came together and put aside their institutional rivalries or institutional reputations or institutional advocacy in order to work together, and they did work together consistently and persistently over 2.5 years to solve these problems, I believe they deserve huge credit for that attempt. Now, within that, were there structural issues? Were there barriers to getting that job done most efficiently? I've laid out some of those barriers. Most of those barriers were put in place by the actions of others. But I'm sure with active evaluation and with future assessment, I believe we will find better ways to bring together that multilateral partnership that's needed in advance of the next pandemic. Very valuable lessons were learned. It wasn't perfect. By no means was it perfect. But I would just not characterize that as a failure in the sense that the billions of people who've now been vaccinated with vaccines through the COVAX initiative, the people who've received oxygen, the health workers who've got access to PPE, the countries that have had access to diagnostics through the ACT Accelerator, I think would disagree. This has not been a failure. But building a system in the middle of a massive pandemic is not the right time to build such a system. So any of the flaws, I think, of structure, any of the flaws of process came from having to build a life raft in the middle of a massive flood, as opposed to building it in advance. And I think there are lessons to learn going forward on how we can build that better into the future. I just wanted to ask if Kate O'Brien was online. She might want to add to that point.
O'Brien, to very quickly, because we need to move on. So many other questions. Ms. O'Brien, if you have to add, or if you want to add something to that. And press the speak button.
Down.
Can we not just put on the screen, press the speak button?
Which is down.
Which is down. We'll come back to that later on. I first now move to the questions, to the next questions. Mrs. D'Amato, please.
Avevo 3 domande, ne faccio una per lasciare spazio.
I had 3 questions. I'll only ask one, though, to leave time. The national plans during pandemics. Now, the World Health Organization asks us to update these plans every 3 years. Now, Italy, which was badly hit, had a plan that was dated 2006. Then there was another report, expensive report, from the WHO, who made a report on Italy, and it was tragic, and yet nobody looked at it. And the scientists responsible for it was bullied and forced to a certain extent to retire. Now, the person responsible in Italy is the Director General of the organization. So the number 2 of the WHO, our citizens start wondering, how is our health protected? Now, during the pandemic, this technical and scientific committee, there was another doctor, Dr. Ricciardi, who's a member of the executive body of the WHO, who closed the National Monitoring Agency for Health. Now, how can we prevent diseases and prevent possible future transmissible diseases and pandemics if then the national services are so bad? And we have members who are members of the WHO, part of it, but don't take their responsibility seriously.
Merci, Madame la Présidente. J'espère que le docteur...
Thank you. I hope that Dr. Ryan can hear us. A couple of questions for you, Dr. Ryan. Firstly, on YouTube, that often contradicts the opinion of local health care officials on the vaccine targeting COVID-19, Robert Mallon, that his video has been censored. What about his video on myocarditis linked to COVID-19, despite the fact that the WHO itself has identified a link between mRNA vaccines and myocarditis? This is more common amongst young men and after a second dose. Has YouTube been in touch with the WHO to talk about myocarditis? How does YouTube communicate with you? How often do you make experts available to YouTube? Another point, WHO deals with the post-pandemic period. Now, I understood in September that the pandemic period was over. We're no longer in a crisis period. What criteria is used to change the period to switch to a post-pandemic period? What about the impact on liability of pharma companies? A final point, the European Medicines Agency gave the green light for use of bivalent vaccines against COVID-19. That began on the 3rd of October last. However, WHO believes that there is insufficient data at the moment. You say that they're not less effective than earlier versions, but we don't know whether they offer an advantage. So what type of vaccine would you currently recommend? And what about prevention, preparation and response to pandemics in general? How do you convey your point of view? Thank you.
Merci. Dr. Ryan. And then maybe afterwards I see that Ms. O'Brien can then join afterwards. Mr. Ryan, Dr. Ryan, sorry.
Okay, thank you. Yes, in terms of, there are just so many questions there, it's very hard to give credible answers to all of them in one go. Absolutely, the issue of pandemic preparedness planning is very important, and many countries had not updated their pandemic preparedness plans in advance of this pandemic. And you know, we're being very clear that preparedness in general around the world was not adequate to deal with the impact of the current pandemic, and we need to learn that lesson. That we need to be much better prepared for the next one, and national pandemic preparedness planning, community resilience, collaborative surveillance, community protection, access to countermeasures, safe, scalable clinical care. All of these issues need to be taken into account when we talk about pandemic preparedness planning at national level. At regional and global level, then, we need to be able to support that national planning, and we need to be able to bring the goods, the services, the technologies to support that national planning, mechanisms to build rapid innovation, rapid scale-up of production, fair and equitable distribution of countermeasures to countries, training, and many other things that need to come from a global level to support and supplement what's going on at national level. Without strong national preparedness, there is no global solution. Global health security, regional health security of the European Union is based on a fundamental principle that we need strong national action plans for public health security. And when we can connect strong national systems, we connect them through global data, global services, global collaboration, global innovation, then we have something that looks like global health security. A purely top-down approach to delivering on pandemic preparedness will not work. Pandemics and epidemics begin and end in communities. We need to build community resilience. We need to build community engagement. We need to build frontline primary healthcare and direct services to people at community level. We can't do that purely with a global lens. So I very much agree with that assessment. With regards to YouTube, we're not a policeman of YouTube. Our job is not to say what is on or off on any particular social media or other platform. We engage intensively with social media platforms to ensure that the best information is getting out there. My view has always been personally that we need to get better at putting strong, positive, scientifically based, evidence-based information to ordinary people so they get to make a good, well-informed health choice for themselves and for their families. Questioning and the ability of ordinary people to question medical interventions is an absolute right. Hesitancy and seeking understanding and explanation for the use of medical products is also an important right that people have. What people don't necessarily have the right to do is to actively spread disinformation and misinformation and actively try to disrupt health responses that are aimed at saving people's lives. And that has happened too often in this global response. We don't have a formal relationship with the YouTubes or others, or have specific meetings with any of those platforms. We do engage with them on improving our messaging, and we want to work more closely with platforms to ensure that there is a good discourse, to ensure that there are good debates, and that the right information is out there for people to access. That's a very important concept for us. And the question on vaccines, currently with vaccines and with the emergence of variants, and specifically variants in the Omicron space and many sub-variants in that, the WHO TAG COVAC, the Technical Advisory Group on COVID vaccination, has suggested, and followed by SAGE, have suggested that booster doses of vaccine using Omicron-based boosters is a useful idea, but that primary vaccination should be with the ancestral strain of vaccine, because that gives the best, broadest protection across all of the different variants. But that booster doses can come from Omicron-related strains, and that's happening more and more with many, many companies coming to the market now with booster doses that contain variant strains of slightly, they have slightly different strains, but most of them are in the Omicron variant side. So we continue to recommend primary vaccination, your first two vaccines to come from the ancestral original strain, and then boosters after that, based on a given country circulating strains, may use variant vaccines that have slightly different composition based on what the government's judgment in a particular country is for what is their most common circulating strain at any one time. Over to you.
Thank you very much. Then Mr. Weimers.
Thank you, Chair. Dr. Michael Ryan, welcome to this special committee, which I propose to be set up to look into the origins of COVID. Now, the Chinese Communist Party refused to share data with the WHO and pressured the WHO team investigating the origins into downplaying the virus' likely lab leak origins in Wuhan, China. The CCP further spread disinformation about the virus originating in Bangladesh, Greece, India, Italy, the Czech Republic, Australia, the United States, Russia, Serbia, Norway, or South Korea. The G7 called for, I quote, a timely, transparent, expert-led and science-based WHO-convened phase 2 COVID-19 origin study, unquote. However, you stated yourself last year that because the WHO works by persuasion, it lacks the power to compel China to cooperate. Dr. Ryan, will the WHO's phase 2 origin study remove everything pointing to China's culpability as in the phase 1 study? What steps has the WHO taken to gain access to China's raw patient data in order to determine the origins of the virus and thereby disprove CCP disinformation? Furthermore, can the WHO shed any light relating to the hundreds of thousands of euros in EU subsidies granted to the Wuhan Institute of Virology, specifically funding under the so-called European Virus Archive project, which also was intended for, quote, the production of viruses, unquote? And does the WHO consider it necessary to strengthen safeguards with regard to so-called gain of function research? Thank you.
Thank you very much. Ms. Donato.
Thank you very much, Mrs. President. Well, I have two important questions. The first one is about the work on the international health regulation, the pandemic treaty. You highlighted the importance of parliaments in your work and collaboration. I need to know if you want to have any collaboration with the European Parliament and especially this committee, letting us have the drafts of this treaty and allowing us to give our opinion, at least, on it, to contribute as a European Parliament to the writing down of this important treaty. The second question is also about the origin of the virus. I'm really disappointed by the fact that after 2 years and a half, your organization hasn't yet been able to give a precise answer about these origins, because we can read several independent scientific studies saying that the origin of this virus is synthetic. The SARS-CoV-2 virus has a synthetic origin, and this can be told not only investigating on the Chinese laboratory, but just investigating on the structure of this virus. In fact, the study that I've just read, published on the Bioxriv magazine, I quote, says that the endonuclease fingerprint indicates a synthetic origin of SARS-CoV-2, and there is a detailed list of reasons for which the structure of the virus cannot be a natural one. So if some of your accredited scientists have arguments to dispute the results of these studies, please do it, but just give us some answers, because you said that the human greed is one of the main reasons basing the diseases and the outbreaks of threats to human health. So if this is true, maybe human greed is behind the gain-of-function research that is responsible for this pandemic and probably for next ones. So the first thing you should focus on is just to forbid gain-of-function research at a global level. Thank you very much.
Thank you very much. Does anybody else wants to raise a question? Mrs. de la Pisa, please.
Y una pregunta muy concreta.
It's a very concrete question. What's your views on how the international health regulation has been complied with when it comes to biological alerts here in this context? Thank you.
That's the shortest question you ever asked, Mrs. de la Pisa. Dr. Ryan, for the final answers, please, you have the floor.
Great, thank you. I'm a little taken aback with some of the assertions being made. We're supposed to be science-based in our observations, yet what I hear here are assessments. You're entitled to your individual assessments, absolutely, as individuals. But you also have to address the evidence in a balanced way. And the paper you referred to is a non-peer-reviewed paper that's just been published as one of thousands of papers that have been published in this area. In terms of the one you just, I believe the one you just referred to, we will wait for that to be peer-reviewed. There have been opinions on all sides of this equation in terms of natural origin, engineered origin of this virus, back and forth, and there is no consensus, absolutely. WHO has been very, very clear to say that all hypotheses remain on the table because there isn't absolute convincing evidence in either direction. And we keep that, and we keep that position open as further evidence develops. And we'll read these new papers with great interest and add them to the Scientific Advisory Group on Origins, which is a group of experts from all over the world who meet now on a constant basis to consider all of this new evidence. In terms of, I can't speak to the issue of the EU's support to gain-of-function studies or support to labs in Wuhan. That's for the European Union and its member states to sort out. I'm not there to provide you with information as to what your own member states are doing or not doing. The issue of lack of power, WHO as a UN organisation, as a member state organisation, has no legal power to enter a country, in the same way that you there in the European Parliament or the European Union has no legal power to enter a European country. You're a federation of states that have come together for economic integration, social integration, justice integration and other things. But there are rights retained by your individual member states. And those rights are sovereign, and those rights are protected. And in this context, the rights of our member states are protected. You may not like that. You may not find that acceptable, but that is the reality. And that is the reality of your own organisation as you sit there. So please, don't come to me telling me about our lack of power. I understand the limitations of the powers that we have. We push to use the powers that we do have to the maximum, and we accept those limitations, and we accept the subsidiarity of member states and their sovereign right to make their own decisions. If member states then wish to argue with each other whether one member state is doing wrong and one member state is doing right, please do. Come to the World Health Assembly and debate it. Come to the Executive Board and debate it. Debate it between your parliament and the other parliaments that you feel are not representing proper practice. But it's not in the power of WHO to enter a country illegally and carry out what would be, under any national law, illegal activity without an invitation to do so. With regard to the different phases of the investigation, we have had teams on the ground. We've had more teams on the ground than any of the European Union teams on the ground or any teams from any of your individual member states. In fact, we've been on the ground a number of times in China. And it is difficult and it is challenging to be able to get the information that we need to get. But at least we're trying, at least we're there, at least we're trying to get access to the scientific information. We're not just standing on soapboxes and pedestals and telling others what they should be doing. And we will continue to try to get to the bottom of this. We will continue to try and find the source of this virus because it's a very important task if we're going to avoid future pandemics. With regard to the last question, which was short in terms of the IHR and compliance with biological alerts, we've seen a huge increase in compliance with reporting to WHO over the last 20 years in relation to the IHR 2005. In fact, I've been around in and out of WHO since 1995. I noticed a huge improvement in compliance. But that doesn't mean that compliance is universal. Some of the countries in your own union are not so transparent in how they engage with WHO in reporting disease. Many countries around the world have real difficulties in being able to report disease, either because they don't have the surveillance systems or because they fear the economic consequences, as in the consequences to the likes of South Africa when they openly and transparently reported their variant. The European Union and members of the European Union were very quick to shut down their air traffic and exclude their citizens. So there are real economic and political consequences of transparency. And countries are punished for transparency and continually and repeatedly punished by parliaments, punished by politicians for being transparent. So we need a new deal. We need a new openness. We need not to have sanctions for reporting. We need to have incentives to report. And we need to put in place checks and balances and supports to countries whose economies will inevitably be disrupted by transparency and by transparently reporting disease. So I think you and us at WHO, we have a job to do in your parliaments and in WHO as a member state organisation in trying to find better ways to create positive incentives to transparency, positive incentives to engagement, and getting rid of the negative incentives which many member states have put in place and continue to pursue, which creates a very difficult landscape for us to operate in. Many countries around the world engage in lab-based research. Gain of function is just one particular methodology. Biosafety and biosecurity are increasingly common. The availability of biomanipulation techniques and technologies for same are increasing. The opportunity for the misuse of viruses is increasing. The question is, are the motivations for misuse increasing? The motivations to misuse viruses or bacteria is a political process. It's a process around whether people wish to do that and whether they want to cause harm or create difficulty. The opportunity certainly increases because the technologies are increasing. But I would ask you to look at countries in the European Union, countries in North America, countries all around the world who are engaged in a vast array of biologic research for the development of pharmaceuticals, for finding better ways to treat disease. It's happening all over the world, and having a stronger biosafety and biosecurity framework in place would benefit everybody. This is just not in one part of the world. And many countries, particularly countries in the north, are investing in studies and investing in work in the south. It's not just one country or two countries. So we do need to have better oversight and better regulation of how biotechnology has been used. We need much more responsible use of life sciences around the world, and we need to be able to understand that we have responsibilities to ensure that all of our life science research, all of our research in the biologic space needs to be done with high levels of safety and high levels of responsibility. And we look forward to working with the Parliament, we look forward to working with the European Union on trying to strengthen both the frameworks for biosafety and biosecurity and also strengthen cooperation and transparency. It's in our mutual interest to ensure that these things happen. And I look forward to continuing to work with you. The WHO looks forward to continuing to work with you, and we very much thank. It has been really the European Parliament and through Charles Michel and others that we saw the initiation of the first idea to create a treaty. And in terms of making sure that European Union countries and the Parliament there have access to, I believe there will be a draft 0 being presented around the treaty in December. The European Union is heavily engaged and involved. Many European countries are represented on the international negotiating body, and I would assume through their good offices that you will see and have an opportunity to contribute to the development of the accord or framework convention or treaty in due course. Thank you.
Thank you very much, Dr. Ryan, and rest assured we will pick that up. This ambition of this COVI committee, not just to the lessons learned, but to draw lessons and have an impact in the negotiations on the pandemic treaty, but also changing the international health regulation, because the two sides of the coin are very important for us. And of course, we do raise questions about the role on China, because we had South Africa earlier on today. South Africa did what they had to do when they discovered the Omicron virus. They reported immediately. And instead of being rewarded for that, the world punished them. So there's something really very wrong. And it's not the World Health Organization to blame. We know what your powers are and not are. But I think together we need to address these issues and strengthen these international treaties and regulations to make sure that we are much, much, much more resilient as a world and we cooperate much more better. But thanks for being here. Being frank, I like that. It's important that everybody can raise their questions here and that you and our other guests can also reply in a frank way. I think that's good. That's helpful. It enlightens us also with regard to our report that we intend to write next year. Thank you very much, Dr. Ryan, and I thank all the colleagues for being here up until the end. It's been, again, a very intensive morning from 9 to almost 1 o'clock. So I wish you a very good lunch and see you next time. And the next time is?
It's 14 November.
14 November, voilà. I think we will go now to the third pillar of our mandate, and that is the socio-economic impact, and I think that will be very interesting as well. Thank you very much.